Hey guys, it's Jake here with Med School Bootcamp. Welcome to our chapter on female reproduction. We're going to start out by talking about the more distal structures like the vagina, and then we're going to move in and talk about the cervix and the uterus and the cancers and pathologies associated with these structures. And then we're going to wrap up by talking about the ovaries and the breast and the pathologies that we can encounter in these parts of the female reproductive tract. So stay tuned and let's get busy. All right, guys, let's get busy talking about internal vaginal pathologies. We're going to be talking about Bartholin gland cysts, imperforate hymen, vaginismus, and atrophic vaginitis. These are all pathologies that are largely going to occur further interior to the labia minora. We're going to have another video that is going to be talking about all the skin pathology of the vagina. That's going to be our next video. So we're focusing on internal structures of the vagina here. So let's go ahead and orient ourselves to some vaginal anatomy to get started. So you'll see here, starting from our external structures, we have our labia majora out here. And then if we were to reflect that, we're going to have our labia minora here. Our clitoris is up here. This is our urethra. And then here, if we reflect the labia minora, we have this hymenal membrane, which you will see is patent. We will talk about pathology later with this membrane. And then here we have our Bartholin gland, which exists at both 4 o'clock and about 8 o'clock bilaterally on a clock face. And then if we were to look at this from the lateral side, and this is the vagina here, and this is going to be our uterus, there are Gartner ducts that line the vaginal cavity, and that is going to be another thing that may be asked on test day, but it's more minor. But I wanted to just orient you guys to this normal anatomy first before we talk about pathology. So talking about pathology, let's start off by talking about our Bartholin gland cysts / abscess. So we pointed out our Bartholin glands, which were these bulbous glands at approximately 4 and 8 o'clock. And essentially these are responsible for producing a variety of fluids to maintain a healthy vagina. And sometimes these can get blocked, and they get blockage, and then they accrue their fluid inside, and it creates a cyst. And this fluid can then go on to become infected. And so essentially it's a progression from Bartholin gland blockage to fluid accumulation in the form of a cyst, and then we're going to get infection. And the way this presents in a classic patient vignette is it's going to be a reproductive age female who may or may not be sexually active, and they're going to present saying, I have some vaginal pain, this is really bad when I'm sitting down, or it's really bad with intercourse. And then a pelvic exam is going to show an inflamed red unilateral Bartholin gland. So usually these are going to be presenting as unilateral. That is classic for this pathology. And so when it comes to management of these, it's pretty simple. It's going to be abscess drainage and then word catheter insertion. So the word catheter is a special rubber tube that facilitates drainage of the abscess. And then in terms of our differential, this could also be a Gardner duct cyst, but this is going to come up much less frequently on the exam. They much prefer to ask about Bartholin gland cysts, so that's why I wanted to really focus on this. So let's just review. It's going to be reproductive age females here, classically unilateral, and then vaginal pain, especially with sitting or intercourse. Let's move on now to talking about our imperforate hymen. And essentially the hymen is a membrane that forms during development just inside the labia minora. An important part of development is that this hymenal membrane should canalize. And when I say canalize, it means essentially make a hole or make a tube. It's just a fancy word for making something patent, making something open. And so essentially, if we take a look here at our vagina that I have drawn here, just to orient you, here's our clitoris and here's our labia minora. Our labia majora would be out here. And then this peachy area of tissue is our hymenal membrane. And normally during development, this gets patent. It becomes canalized, it opens up. However, what can happen in patients with imperforate hymen is that this canalization does not happen. And so essentially they are going to present with a classic patient vignette as a person who is about to start menstruating. So we're thinking 12, 13 years old, and they're getting this cyclic monthly abdominal pain. And this is actually them initiating menses. However, they are not producing any blood or products of menstruation. And this is because everything is trapped behind this hymenal membrane. And it's going to present as a bluish purple bulge because essentially these cyclic menses are getting trapped behind this hymenal membrane, and it's causing pelvic pain, it's causing abdominal pain. And then if you were to do a pelvic exam, you would see this bluish discoloration, which is all of the products of menses that are trapped here behind this tissue. And in terms of treating this, it's pretty easy. You just have to go ahead and open up this membrane. This can be done surgically, and it's going to relieve these menses that are backed up, and it's going to help with the canalization of this hymenal membrane. So in terms of review of our imperforate hymen, it's going to be failure of our hymen to canalize during development, and this is going to present as a pubertal age patient with cyclic monthly abdominal pain. This is technically a form of primary amenorrhea because even though they are initiating and having their menses internally, this is not able to be finished by actually pushing those products out of the vaginal orifice. And we're going to say this is going to present with a blue or a purple hymenal bulge, and then the management here is going to be a hymenectomy. Now I wanted to point your attention down here to our diagram here where we have different types of imperforate hymen. So here would be a normal hymen where we have this vaginal orifice that is open here. However, we can have variations of imperforate hymen. So we talked about the completely imperforate hymen, which is completely closed, where we can have things like cribiform, which is a collection of little dot holes, or we could have a septate hymen. It's not incredibly high yield to know these different variations, but I wanted to put it here for you guys if you're interested. I would really focus on the fact that we're going to have this cyclic monthly abdominal pain and this blue purple hymenal bulge. That's going to be what is high yield on exam day. Now let's move on to talking about vaginismus. And vaginismus is going to be involuntary contraction of our vaginal muscles, especially with insertion of something. So this could be insertion during intercourse, this could be tampon, this could be pelvic exam. And essentially we're going to have this involuntary contraction, and this is going to lead to vaginal pain. And this can be with insertion of anything, even during voluntary insertion. And so this is going to present as someone with pain during intercourse or pelvic exams despite willingness to have something inserted in the vaginal canal. And usually in classic patient vignettes, this is going to be interlaced with some sort of mental health issue. So usually we're thinking anxiety or depression or maybe a history of sexual abuse. That is going to be really high yield in connecting this to vaginismus. So I'm going to highlight these three things for you guys because they are nearly always going to be in a question around vaginismus. And then this is going to be clinically diagnosed by visualizing this vaginal contraction that's going to happen during a pelvic exam. And in terms of treatment of this, it's not super high yield on step one, but it's essentially going to be mental health type treatment. So like cognitive behavioral therapy and working through patient with like relaxation exercises and things like that. Finally, let's talk about our atrophic vaginitis, which is going to be atrophy of vaginal tissue in the setting of low estrogen. And so our low estrogen here is going to create a low vaginal blood flow state, and this is going to decrease the secretions from our vagina, leading to vaginal atrophy. So we mentioned earlier on in this lecture that things like the Bartholin glands and the Gartner ducts are really important for lubricating the vagina and ensuring that it's in a healthy state. However, in low estrogen states, this activity starts to decrease, and some classic low estrogen states are going to be menopause and pituitary dysfunction, or maybe a patient is on an aromatase inhibitor, a classic example which is anastrozole. And these patients are going to present with the complaint of thin and dry vaginal skin. They may have itching or pain because this area is not well lubricated and it's causing friction, and we're getting like loss of flexibility in those tissues. And then we can also have altered vaginal pH because these secretions are not at their normal amounts. And so you may have a patient who gets a complication from this altered pH. Perhaps a candida would be a classic infection that's going to occur with altered pH. And remember, this is going to present as like a cottage cheese-like discharge from the vaginal orifice. So in terms of fixing this and treating this, we can identify the underlying cause of their low estrogen state. And if this is manageable, we can fix that. But if it's not, like in the case of menopause, then we can go ahead and provide topical estrogen creams, which are going to help revitalize this vaginal tissue. And we can also provide water-based lubricants to help with things like intercourse or tampon insertion, etc. So in terms of a high yield review for this video, it's important that we focus on our anatomy. So knowing our internal structures are going to be really helpful. And then knowing that Bartholin glands are usually going to be unilateral and present with pain with sitting and intercourse. And this is due to blockage or infection of these glands. In terms of imperforate hymen, the cyclic abdominal pain accompanied by this blue/purple hymenal bulge is going to be really high yield, and this is going to be managed surgically. In terms of vaginismus, I really want you guys to focus on the incorporation of some sort of mental health aspect to these question stems, and the fact that it's going to be insertion with anything despite willingness that causes this involuntary vaginal contraction. And then finally, we wrapped up with atrophic vaginitis, which is due to our low estrogen states. Classically, this is going to present in a menopausal patient. However, it can be anyone in a low estrogen state, and we're going to manage this with estrogen cream as well as water-based lubricants. So I really hope you guys enjoyed this video. I can't wait to see you guys in the next one. Bye! All right, guys, let's get busy talking about our vaginal skin pathology. We're going to be talking about lichen sclerosis, lichen simplex chronicus, and lichen planus. You will notice that these all start with lichen, and I hope this word lichen can orient you to the fact that these are going to be skin or epithelium-related processes. We're going to be talking about diseases of keratinized skin, like this skin here on my hand, as well as skin that is non-keratinized, like those on our mucosal surfaces, like inside of our mouth or inside of our vaginal orifice, for instance. And it's going to be our first two pathologies, lichen sclerosis and lichen simplex chronicus, that are largely going to be on keratinized skin, and then our lichen planus can be on both keratinized and non-keratinized skin. So let's go ahead and get busy by talking about our lichen sclerosis. And this is going to be an inflammatory condition of really unknown origin, so you don't need to know the pathophysiology for the step 1 exam. However, you do need to know some facts about who gets this disease process and what it's going to look like. So this is going to be most common in our perimenopausal patients or postmenopausal patients. So you can expect like age like 40 to 60s or 70s here in terms of the patient who's going to present with this. And it's going to look like a porcelain white plaque with violaceous borders. And now what does that exactly mean? So let's kind of review here. The porcelain white plaque is going to be what I'm outlining here. So you can see that this tissue is really shiny, almost like white porcelain. And then on the periphery, we're going to have like this violaceous tissue. So violaceous tissue is oftentimes described as like purple or pink in appearance. And so you're going to see this combo with the lesion centrally looking white and porcelain and then peripherally looking violaceous. And additionally, we can have these plaques that can flake or slough because they can be itchy at times. And so you can imagine with increased itching, then you're going to have sloughing and irritation. And how this patient is going to present in a classic vignette is going to be our patient whose age approximately 45 to 60 or 70 with really severe itching. So this is just itchy, 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 itchy. This is going to be the chief complaint. And they can also complain of pain with intercourse and or defecation because these lesions can occur anywhere in the anopelvic region, and so they can infiltrate the anus or the vagina, and so any type of activity down there can cause pain in these patients. In terms of managing this patient, it's important to get a biopsy of this lesion because by its appearance alone, this silvery white plaque, this could be a squamous cell carcinoma or it can be lichen sclerosis. And so this punch biopsy is going to be really important because even though lichen sclerosis is a benign disease, the punch biopsy is going to rule out squamous cell carcinoma. And if we rule out squamous cell carcinoma, we can simply treat these with steroid cream. However, if it was squamous cell carcinoma, we'd have to go down a different route of management. In terms of the histology, if this indeed is just a simple lichen sclerosis, we're going to see atrophy of epidermal tissue, hyperkeratosis, and dermal fibrosis. And this makes sense, right? Hyperkeratosis is going to be extreme growth of that squamous layer. So you're going to expect a really thick layer of these squamous cells right up at the top here, which is a picture that I have for later, but this is showing you the hyperkeratosis layer where that would occur. And then dermal fibrosis also makes sense because I usually think of fibrosis as like scar-like appearing tissue, and you can see that this looks like a scar-like lesion. That white, shiny, porcelain-like skin is very much related to this hyperkeratosis and dermal fibrosis that you would expect to see on histology. However, it is unlikely that you'll see a picture of the histology on this exam, but I just wanted to mention it because it may come up in a question stem in written words. Let's move on now to talking about lichen simplex chronicus, which is going to be all about itching, and it's specifically going to be itching due to a secondary cause. So our etiology here is going to be habitual scratching or rubbing, and this is going to be secondary to another condition. So other conditions that I'm thinking about could be like eczema or a fungal infection like Candidal intertrigo. Perhaps someone is having an allergic reaction to some type of clothing that they're wearing chronically. These are all underlying conditions that could lead to chronic itching. And so essentially these patients are going to have some sort of underlying pruritic anopelvic disease. And I gave you guys some examples, but it could really be anything. As long as they're scratching and scratching, it's going to lead to this. And so our presentation is going to be this thick, leathery vulvar skin with or without signs of excoriation. And excoriation is a fancy word for scratching. And so you can see here in this circle that I'm highlighting, this is that thick, leathery vulvar skin. This is how it would appear, and it looks like someone's just been like really scratching and irritating that area for a long period of time. In terms of our histology, we would expect to see hyperplasia of the squamous epithelium, so very similar to what I was previously talking about with our lichen sclerosis. That keratotic layer is going to be increased. It's going to experience hyperplasia because it's trying to defend or protect our skin from all the damage that is occurring there. In terms of our management here, there's no cancer risk, and so it's going to be all about treating that underlying cause of the itch here, and that should resolve this along with things like moisturizers. Lastly, let's wrap up by talking about our lichen planus, which is going to be really high yield on the step 1 exam because there are little minutiae that they love to ask about in relation to this disease. So let's start out by talking about some of the pathophysiology. This is all going to be T cell mediated, specifically our CD8 positive T cells, and we're going to find these T cells specifically at the dermal epidermal junction, and this is called interface dermatitis. And I want to highlight a few more things about the histology before we zoom in. We're going to be looking for things like hypergranulosis, sawtooth reedy ridges, and lymphocytic infiltrate. So keep in mind our lymphocytic infiltrate here is going to be our CD8 positive T cells. So as we zoom in and look here, we're going to notice some things here. So I want to point out here is a bunch of lymphocytic infiltrate. What I'm tracing along here is the border between our dermis and our epidermis. So let me go ahead and put that in green. This is our dermal epidermal junction with our dermis down below and our epidermis above. And normally in our dermis, we do not expect this many purple dots. There is a lot of lymphocytic infiltrate here. Usually this is a lot more pink and lacy and full of fibroblasts, which appear more pink, but this is just chock full of these lymphocytes here that are CD8 positive. And essentially, I want to point out something else. You're going to see that these borders, there's times where it kind of like stretches down here, and these are called like sawtooth reedy ridges. So like this really jagged appearance to this interface between the dermis and the epidermis is called sawtooth reedy ridges, and that's a high yield description that they like to reserve for lichen planus. Additionally, you're going to see hypergranulosis. So in my blue here, I'm highlighting this layer of cells that is full of granulocytes, and this is also going to be expanded during our lichen planus disease. And so these are some high yield things to note about our patients with lichen planus on biopsy. Now, in terms of the presentation, this is classically not going to present as someone with a vaginal complaint. This is going to be a person who's complaining of bilateral lesions that are described using a mnemonic called the 6 Ps. So the 6 Ps apply to disease that's usually going to be on the extremities. So we're thinking like the legs and the arms, and these are going to be pruritic lesions, so super, super itchy here. And they're going to be pink and purple. They're going to be planar, polygonal, and described as papules or plaques. So these are all hot words for describing lichen planus, and these we would expect on the extremities. But we're talking about vaginal disease here in this video. And so in our mucosal areas like the mouth or vagina, we actually expect something else, and that's going to be something called Wickham striae. And Wickham striae are going to be described as these lacy white reticular deposits. And so you can see here in this mucosal lining, we have this really like lacy reticular finding. They tend to be like really long and really thin, and this is characteristic of lichen planus in a mucosal distribution. So outside on keratinized skin, we're going to expect purple lesions, but on mucosal skin, we're going to expect white, lacy, reticular lesions. And this is a high yield distinction in order to be pointing out on test day in terms of our lacy white reticular deposits called Wickham striae on our mucosal surfaces. Now, I also want to mention that there are some epidemiological fast facts that they like you to know in terms of the connection with hepatitis C, as well as autoimmune conditions like vitiligo and ulcerative colitis. Those are oftentimes going to be present in the history of a patient who is presenting with lichen planus. In terms of our management here, it's going to be topical steroids because we know this is all about lymphocytic infiltrate. So if we give steroids, we're going to reduce some of that inflammation. And that's going to be the mainstay of treatment for this disease process, in which a lot of the pathophysiology is largely unknown. We just know what it looks like on histology and what its associations are. And in terms of treating it, we just use our steroids. So in terms of a high yield review for our lichen sclerosis, it's important to recognize those white porcelain plaques with our violaceous borders, and then knowing that it's going to be a punch biopsy that helps you differentiate from squamous cell carcinoma. A normal punch biopsy just showing atrophy of epidermal tissue and hyperkeratosis with no evidence of dysplasia like we would expect in SCC. In terms of lichen simplex chronicus, it's all about scratching and rubbing, and this is going to be due to something underlying, like perhaps a fungal infection in the groin. That would be a classic example on a question vignette. And then in terms of lichen planus, we have a bunch of fast facts to know in terms of the histology with our sawtooth reedy ridges and lymphocytic infiltrate, as well as the connection to hepatitis C and underlying autoimmune conditions, and then knowing that it's going to be our white Wickham striae that are lacy and reticular on our mucosal surfaces, and then our 6P mnemonic for our keratinized skin lesions. So I hope you guys enjoyed this video. I can't wait to see you guys in the next one. Bye! Alright guys, let's get busy talking about vaginal cancer. In this lesson, we're going to be covering vaginal cancers of the exterior vagina. In these first two pathologies, these tend to be more on the skin and vulva of the vagina, whereas our later two pathologies are going to cover more of the interior vaginal structures. That's a great way for you guys to start organizing your thoughts as we approach this lesson. Let's start out by talking about our extramammary Paget's disease. But before we can talk about vaginal Paget's disease, I think it's good to have a handle on our Paget's disease of the breast, because that is what we are referencing here. So if you'll notice here, we have a breast here with Paget's disease of the breast, and this is going to present as a really itchy, almost eczematous, erythematous looking lesion that has well-defined borders. They tend to be very, very red, and they have this characteristic look here, and this is exactly what the tissue is going to look like in the vagina as well, and that is why it gets its name as extramammary Paget's disease, because it is happening in the vagina. Now, I also want to take a look at this characteristic histology here. So this histology here is classic Paget's pathology. It is so beautiful in my opinion, and it's going to be defined by these large cells with clear cytoplasm. So you'll notice these like large evacuated cells. These are classic of Paget's disease, and Paget's disease also tends to have this really shiny, beautiful red keratinized layer as well. It's beautiful histology. I would commit this image to memory because it's going to show up in the breast and also in the vagina. So I just want to note that our histology and our gross picture here with this skin lesion are going to be the same for both the breast and the vagina. However, there is a key differentiating factor here, and that is there a low risk of underlying invasive carcinoma in our vaginal disease versus in our breast disease, this risk is a lot increased. So there's a much higher risk of invasive carcinoma in disease of the breast as opposed to the vagina. So in terms of our pathophysiology, we talked about the fact that this is an adenocarcinoma of the vaginal tissue, and so adenocarcinomas tend to be more in like fluid producing areas, and we know that the vagina is a very much a fluid producing structure, and so we expect this to be classified as an adenocarcinoma, and we went over some of the histology of this adenocarcinoma with those cytoplasmic clear large cells. And in terms of our presentation, we talked about the pruritus, the redness, the crusting, and then also there can be the presence of ulcers as well. And then in terms of our histology, we went over these classic Paget cells. In text, these could be described as intraepithelial adenocarcinoma in situ, or as these large cells with a lot of abundant clear cytoplasm. Let's move on now to talking about our vulvar carcinomas. And in terms of our vulvar carcinoma, this is most often going to actually come from our cervical squamous cell carcinomas. So we know that cervical squamous cell carcinoma is very, very common, and this can actually spread to the vagina and the vulva, and this contiguous spread is the most common way that we actually get this vulvar carcinoma. So we know that our HPV infections are notorious for causing these squamous cell carcinomas, and these types are going to be 16, 18, 31, and 33. These are going to be the same exact types that are causing our cervical squamous cell carcinoma. Additional risk factors are going to be smoking or long-standing lichen sclerosis, which is going to be an important part of our discussion and our differential. So in terms of our squamous cell carcinoma, we talked about this being the most common type of cervical disease, and this is what's going to spread to become vaginal disease. So it's important to note that this contiguous cervical spread is going to be the most common form of spread. In terms of our presentation, I want you guys to note that it's going to be very similar to our long-standing lichen sclerosis. So we're going to expect very thin, shiny vulvar tissue and an atrophic vagina, and we can also experience patients who are complaining of dyspareunia, painful, itchy, or bleeding vulvar ulcers. And I want to note that the first three bullet points are going to be very similar to our lichen sclerosis. Lichen sclerosis is going to look like this. However, it does not usually have ulcers, and so ulcers are going to be something that is going to be unique to vulvar carcinoma. And since these disease processes are so similar in their presentation, it makes getting a biopsy of these super, super important. So if we're to look here at the biopsy of our vulvar carcinoma, you're going to notice things like keratin pearls and also intracellular bridges. I'm circling two of them here. There's the these long linear structures, and we can also see abundant eosinophilic cytoplasm here. And this is something we would not expect to see if this was long-standing lichen sclerosis, and that's why the biopsy is so important, because we know that there is a small risk of cancer with lichen sclerosis, and so we need to be able to definitively say this is lichen sclerosis or this is squamous cell carcinoma, because that's really going to affect our management. So let's just review that histology is going to show squamous cell carcinoma evidence such as keratin pearls, intracellular bridges, etc., and that's going to be really important in this differential. Let's move on now to talking about our clear cell carcinoma, and clear cell carcinoma has just a couple of really high yield hitting points that you need to know, and you should nail this on test day. So in terms of those high hitting facts, it's all about diethylstilbestrol exposure, and this is also going to be abbreviated on test day as DES. So this DES is a type of synthetic estrogen that we used to give people. We don't do it anymore because we know it has this connection with clear cell adenocarcinoma. And essentially what happens is when a patient is exposed in utero, it's going to be the fetus, who eventually will grow up to be our patient, who's going to develop this vaginal adenosis. So it is not the mother who is developing vaginal disease here. It is actually the fetus inside the mother who has this DES exposure, who will go on to develop this type of vaginal cancer. And this is going to be described in text as persistence of glandular columnar epithelium, and this is classically going to be described as presenting in the upper 2/3 of the vagina. Let's wrap up by talking about our sarcoma botryoides, and essentially this is going to have 4 big hitting points on exam day that are going to help you get questions right. In terms of pathophysiology, this is going to be a subtype of rhabdomyosarcoma, and we know that rhabdomyosarcomas are very common in our pediatric population, and the vaginal derivative of this is no exception. So we classically are going to see this in a young female less than 4 years old. And this is going to present as a pelvic exam or a patient complaint of a large, clear, grape-like segmented mass protruding from the vagina. And so if we take a look here, we see that this mass that I've drawn here resembles grapes. So it looks like a cluster of clear grapes, and it's going to just be protruding right out of the vaginal orifice. And I drew this little green stem here to remind you guys that on test day, this is usually described as grape-like when they write this out in text. The important histology to know here is that these are going to have Desmond positive spindle-shaped cells. That's going to be pretty high yield when they describe this histologically. You won't need to recognize this as a picture. You'll just need to recognize that phrase in text. And so in terms of the details here, there's basically 4 main points that I think are really a high yield on test day that should help you get these right. So in terms of our high yield review, when it comes to extramammary Paget's disease, it's important to remember that the skin findings and the histology findings are going to look exactly the same, but it's going to be the prognosis that is going to differ between the breast and the vagina, with the vagina being better and the breast being a little bit worse. When it comes to vulvar carcinoma, it's going to be important to know that this is due to HPV infection most often, and it's going to be most often coming from the cervical region. Additionally, it's important to know how to differentiate this from lichen sclerosis. And we talked about these 3 bullet points that are going to be similar between the two, and the fact that vulvar carcinoma may have ulcers, whereas lichen sclerosis likely will not. And then it's going to be our histology that really clinches the diagnosis for us. When we see dysplasia and things like keratin pearls, this is going to point us in the direction of a carcinoma instead of long-standing lichen sclerosis. In terms of clear cell adenocarcinoma, it was all about DES exposure, and the vaginal cancer was going to happen in the fetus when they grow up, and it's going to be in the upper 2/3 of the vagina. And then we talked about sarcoma botryoides, which is going to be a rhabdomyosarcoma happening in patients less than 4. It's going to show up with this clear multiloculated grape-like mass, and it's going to be important to note that this is going to have Desmond positive spindle cells when it comes to a histological description. I hope you guys enjoyed this video. I can't wait to see you guys in the next one. Bye! Alright guys, let's get busy talking about polycystic ovarian syndrome, also called PCOS. This is going to be one of the most common pathologies affecting women, and it's going to affect both the reproductive and endocrine portions of the female body, so it's going to be really high yield on the step 1 exam. And I want to say that there are some presenting symptoms that you need to recognize on exam day, and additionally there are some key pathophysiological pillars of this disease process that you need to know. Now with that said, the pathophysiology of PCOS is not completely understood. However, I will guide you towards the key things you need to know in terms of the pathophys and how this connects to the symptoms you're going to see on exam day. So let's go ahead and get into it. And I want to start out by talking about the presentation because I think this is going to be the most high yield. So it's going to be signs of polyendocrinopathy in a reproductive aged female. And these signs are going to go across a few different systems. So we can see obesity as well as acanthosis nigricans. And for those of you who are not familiar, acanthosis nigricans we cover in the derm unit, and it is caused by hyperplasia of the epidermis, and it leads to this dark pigmented skin that I'm highlighting down here. And this is usually found in the axilla or along the neck, and it's going to point you towards a patient that either has diabetes or PCOS. Those are the two most common pathologies where you will see acanthosis nigricans, and it is due to insulin resistance. That's what causes this disease process in the skin. Additionally, in our PCOS patients, we can see hirsutism and acne. So if you have a patient that is obese and they have hirsutism and acne, your PCOS bell should start to ring. Now, the last thing that really clinches the triad or the constellation of endocrine symptoms is some type of reproductive pathology. So it's going to be changes in the menstrual cycle like amenorrhea or oligomenorrhea, or perhaps we're going to have enlarged ovaries, and these can be painful, especially with changes in hormones. And then additionally, we can see infertility in patients who are trying to get pregnant. So now that we know this constellation that kind of branches across a few different systems, let's talk about the pathophysiology. And I want to talk about two main pillars that are the cause of PCOS. And the first one is going to be increased adipose tissue. And I like to make my primary insults in red, and then we're going to talk about how this increased adipose tissue is going to go on to change a few things in the body. So I'm going to follow this up by highlighting in pink. So our increased adipose tissue is going to lead to increased estrogen. And this is because we know that adipose tissue can produce estrogen in the periphery. So if you have a lot more adipose in your body, you can produce a lot more estrogen. We also know that patients with larger burden of adipose tissue and higher BMIs, they're going to have insulin resistance, and therefore they are going to create more insulin. Now, this connects a little further down the chain in that patients with increased insulin resistance have changes in their liver. And we know that the liver is a synthetic organ, and it's responsible for making a number of proteins. One of the important proteins is going to be sex hormone binding globulin. And we see decreased levels of sex hormone binding globulin in our patients with PCOS due to the fact that they have this insulin resistance caused by increases in adipose tissue. And we know that sex hormone binding globulin is responsible for maintaining a balance between testosterone and estrogen in the periphery. And so if we have decreased levels of this, we are going to start to see hormonal effects of that imbalance. And this is going to present as free estrogens and androgens that are floating throughout the body that are not bound to sex hormone binding globulin, and so they increase a much stronger effect throughout the body. Let's move on now to talk about our next pillar in the disease process, which is going to be increased levels of luteinizing hormone. I'm putting this in red because this is a primary insult. I'm going to follow this up in this turquoise color to show you guys the effects of increased luteinizing hormone. So essentially, the balance between LH and FSH is going to be disrupted, and this is going to cause anovulation. And so essentially, we're going to get an ovarian follicle that is going to grow really big into a giant cyst. We know that our androgens, our testosterone, is going to be produced by our ovarian theca cells, and that's important to know that these are the squamous cells on the outside of the follicle, and then our granulosa cells on the interior portion of the follicle are going to be producing estrogen. So we're going to see increased levels of estrogen, and since we get stuck in this follicular phase and we never make it to the corpus luteum phase, we're going to have decreased levels of progesterone, and this is going to lead to endometrial hyperplasia. And I want to kind of highlight this back on our menstrual cycle graph down here. You'll see that if we direct our attention down here where I'm highlighting, in PCOS, we tend to be stuck here in this beginning portion of the cycle that is very estrogen heavy. So we have this big pink estrogen line here, and this is causing growth of the endometrial lining. However, we never make it past this ovulation where the follicle is supposed to burst open. Instead, we have this huge burden of cysts, and so we never make it to the progesterone phase, which is guided by this darker purple hump in terms of our hormonal axis. And so we have decreased progesterone, increased estrogen, and this is what leads to things like anovulation and endometrial hyperplasia and these menstrual cycle irregularities that patients with PCOS experience. So to summarize, essentially what's happening is we have two main pillars, our increased adipose tissue and our increased luteinizing hormone, and these are leading to the increases in three main hormones. We're going to have increased estrogen, which we denoted up here, as well as increased estrogen, which we denoted down here. We're going to have increased levels of insulin, which leads to insulin resistance, and we're also going to have increased levels of androgens. So a lot of androgen production, and as well as a lot of androgen agonism due to lack of sex hormone binding globulin. And so if we look down at the symptom profile that we discussed at the beginning of the video, we're going to see that we have our increased insulin resistance, our increased androgens, and our increased estrogens. And these led to all the symptoms that we initially described. So we have the obesity and the acanthosis nigricans due to the insulin resistance. We have the hirsutism and acne from our increased androgens. And then we have our amenorrhea, oligomenorrhea, our enlarged ovaries, and the infertility due to the fact that we're stuck in the proliferative phase of the menstrual cycle, which I mentioned here, that is dominated by estrogen, that is dominated by follicles, that is going to turn into these cysts that never rupture, that never make it to that luteal phase that's dominated by progesterone. So let's go ahead and move on to talk about our lab values, which I'm going to highlight in this darker blue color. And these are really quite self-explanatory if you know the pathophysiology. We're going to see increased levels of LH as well as increased FSH, but I want you guys to pay attention to this relationship because here in PCOS, they're both going to be increased, but LH is going to be increased even more. And this is opposite from menopause, which is also going to present as menstrual irregularities in an older woman, where we usually expect our FSH to be a lot bigger than our LH, even though they are both increased. So that's going to be an important differentiating factor on test day when looking at lab values of FSH and LH that are both elevated. We expect our LH to be much more elevated than our FSH in polycystic ovarian syndrome. And then we talked about the pathophysiology leading to our increased estrogen and our increased testosterone. This is what we would expect on our lab values in someone with PCOS. Then, if you were to put an ultrasound on these patients with PCOS, you would see enlarged ovaries with multiple cysts. So let's take a closer look at this over here. If we have a gross specimen, it would look something like what I have here, this multi-loculated ovary that can be quite large. You can imagine that patients with a large ovary like this would be at risk for torsion because this large ovary could easily rotate on its own axis and cause torsion. So if you had a patient with a known history of PCOS who's presenting with acute abdominal pain, torsion might be something you have on your differential. Now let's also look at the ultrasound findings, and you'll see that this is the outline of our ovary here, and we have these multiple loculations that are hypoechoic on ultrasound. And this represents all the cysts within the ovary that have not ruptured, that are making this a really heavy estrogen producing ovary that is causing all of these problems. So let's go ahead and zoom out now and talk about some of the treatment for our PCOS patients. So one of the initial treatments is going to be weight loss and metformin because it's going to help with that adipose tissue burden. So I'm going to connect this little purple line to the insulin resistant bullet here because this is going to address that portion of PCOS. The next thing in our arsenal is going to be hormonal contraceptives, and this is going to help with the imbalance of estrogen and progesterone. So we can prescribe exogenous hormones like progesterone and estrogen in an attempt to achieve a balance depending on the symptom profile, the menstrual cycle irregularities that our patient is experiencing. Now, the next class of treatments is going to be all related to how our hormones are operating in the periphery. So if we take a look here, spironolactone, finasteride, letrozole, and flutamide are all going to be acting on hormones in the periphery somehow. So spironolactone is going to be a steroid receptor antagonist, so it's going to block androgens directly at the receptor and hopefully decrease some of the effects of those androgens like hirsutism and acne. We have finasteride, which is going to inhibit conversion of testosterone to DHT. It does this via inhibition of 5-alpha reductase. This is going to be great for patients who may be complaining of male pattern hair loss and acne because we know that DHT is a very potent androgen, so if we can decrease its levels, we're going to help help with those symptoms. Next, letrozole is going to block conversion of androstenedione to estrone. So essentially, we're blocking conversion of those peripheral steroid hormones in an attempt to reduce some of the symptom burden. And then finally, flutamide is going to be very similar to spironolactone. It's going to be an androgen receptor antagonist. It's going to prevent some of those adrenergic effects from our overproduction by both the ovaries and the adipose tissue. And then finally, in our patients who are trying to get pregnant and are experiencing infertility, we can give them clomiphene, which is going to promote ovulation. These patients have a lot of difficulty ovulating because they have these cysts that just refuse to burst. And so clomiphene is really going to agonize those cysts to release their eggs and hopefully allow a patient to get pregnant. I want to wrap up by giving you guys a quick differential and some lookalikes with some similar pathophysiology to PCOS. So let's start by talking about acromegaly, which can present similarly. These patients are going to present with really coarse features that can sometimes be mixed up with hirsutism. They tend to be larger individuals. They tend to have really stern, broad features, large hands. And this is going to be due to the fact that they produce large amounts of IGF-1, which is a type of growth hormone. And we know that insulin is also a growth promoting hormone. And so both patients with acromegaly and diabetes and PCOS are going to show up with insulin resistance. And so a key in differentiating PCOS from something like acromegaly would be to do a glucose challenge test. In acromegaly, we would expect to see increased levels of our IGF-1 after a glucose challenge test, and that's going to be a hot word on exam day, is that glucose challenge test and measuring IGF-1. If it's elevated afterwards, we're looking at acromegaly. Let's look at our next thing on our differential, and these are going to be our tumors. So Sertoli, Leydig, and granulosa cell tumors. These are all steroid-producing tumors. We might expect some type of mass identified on ultrasound or on CT, and if we were to get a biopsy, we might expect Cal-Exner bodies in the case of granulosa tumors, which make estrogen, or perhaps Ranke crystals in our testicular tumors that are producing androgens. So that's another thing to have on your differential. Next on our differential, congenital adrenal hyperplasia, specifically 21-alpha hydroxylase deficiency. This is going to lead to precocious puberty in our younger patients, and this is also going to present with things like hypotension due to the fact that steroid hormones are being shunted all towards testosterone and estrogen, and we are not able to make aldosterone or cortisol. And so this is going to be someone where you expect hirsutism or precocious puberty, as well as some type of issue with blood pressure or some other absence of a steroid hormone that is necessary. Next, let's talk about exogenous steroids. Usually this is going to be a buff guy who goes to the gym a lot with a lot of acne, oftentimes on the back, and you're going to be expecting someone with really large muscle mass, and they're going to have somewhat of a similar PCOS presentation. It could be a college athlete, especially a female athlete who really wants to get big for a certain competition, and you're going to have some suspicion of like body dysmorphia or performance and expect them to be taking some type of exogenous steroid that might be a mimic of PCOS because it could present with infertility or hirsutism or acne. And so it's important to be able to tease that out in your questions as you read through. And then finally, we have cirrhosis, which is usually going to be in our alcoholic patients. However, I wanted to stick this one in because cirrhosis also results in lower levels of sex hormone binding globulin, which we talked about before. And so oftentimes you'll see a male with gynecomastia if he has cirrhosis, and this is because he has an imbalance of estrogen and testosterone due to the lack of sex hormone binding globulin. And I want you guys to be aware of this interesting pathophysiology because it does come up in questions about our cirrhotic patients. So I hope you guys enjoyed this video on PCOS. Can't wait to see you guys in the next one. Bye! Alright guys, let's get busy talking about our uterine pathologies. We're going to be talking specifically about uterine pathologies relating to different layers of uterine tissue. So let's go ahead and do a quick review of those layers to orient ourselves to talk about pathology here in a couple of minutes. So here, if we look at our uterus, we're going to have layers that are going to start closer to the uterine cavity and then move our way more out. So if we look here at the level that is most closest to the uterine cavity, which I'm outlining in purple, this is going going to be the uterine functionalis, and this is composed of glandular tissues, and this is the portion of tissue that is grown and then shed with each menstrual cycle. Now, if we went one layer further back, we're going to have this blue layer, which I'm highlighting, and this is the uterine basalis, and this is a population of cells that is responsible for regenerating the functionalis every month after menses. And so you can think of it as a regenerative layer, and it's important in order to support the functionalis above. And then if we go one more layer out, we're going to have this much thicker layer, which I'm highlighting in orange, and this is going to be our uterine myometrium, and this is the part of the uterus that is responsible for contraction and support, and it's going to be the outermost layer that we talk about in these pathologies. So now that we've talked about that review, I want to also mention that I'm going to be highlighting things in red, and that's going to emphasize trauma as the inciting portion of our pathology, and I'm also going to be highlighting things in green, and that is going to signify hyperplasia. So there's going to be kind of two layers of highlighting going on. The layer that we're talking about in terms of the uterine layers, and then red or green for trauma or hyperplasia. So let's go ahead and get started by talking about our adenomyosis. And I'm going to be highlighting here in blue because this is all about the uterine basalis layer. And essentially what happens here is we have hyperplasia of our endometrial basalis layer, and this is going to cause invasion of endometrial tissue into the uterine myometrium. So remember here, we're talking about hyperplasia here, and we're talking about our blue basalis layer. So if you go back to our diagram, essentially this blue is growing out of control into the myometrium, and this is going to lead to pathology. I'm going to erase this increase in blue here because we need to use this diagram later, but you guys get the idea of what is happening, and this is all going to be due to increases in estrogen. So if you have a patient with PCOS or on hormone replacement therapy, or perhaps an ovarian tumor that is producing estrogen, we are going to get increases in estrogen, and this hyperestrogenic state is what is causing this hyperplasia of the basalis layer. So we're expecting a patient who is between 30 and 50 years old complaining of dysmenorrhea or menorrhagia, which are fancy words for pain with menstruation or heavy menstruation with a lot of blood, so dysmenorrhea and menorrhagia. And this makes sense, right? If our basalis is growing into the myometrium, we could imagine this would cause pain, and if it's growing out of control, perhaps it's contributing to a bigger functionalis, leading to greater amounts of bleeding each month. Now, here's the highest yield part of this pathology, and it's going to be this description of a soft and boggy, uniformly enlarged globular uterus. This is so high yield. This is how they will describe adenomyosis to you. The histology findings of this are not as high yield as the physical exam description that I just described. It is so high yield, and we also may present with tenderness in the uterine or pelvic area as well. And in terms of our management here, it's going to be all about reducing this hyperestrogenic state. So we can use GnRH agonists like leuprolide, which are going to kind of reset the pituitary hypothalamic axis, and they're going to bring that estrogen level back down to a normal amount. And we can also move on to hysterectomy if the basalis has just grown way too far into the myometrium and it needs to be removed altogether because it's causing excessive symptoms that cannot be treated medically. Let's move on now to talking about endometrial hyperplasia, and you'll notice that I have switched to purple now because we are talking about our uterine functionalis layer, or the layer where we have our glandular tissue. This is the layer that is grown and shed every month with menses, and essentially there's a very similar process happening here, but now we're talking about the functionalis layer. So we have increased estrogen, and this is leading to hyperplasia of the endometrial glandular tissue, and I want to highlight in green here over our hyperplasia to note that this is an error in hyperplasia here, and that's going to be important. They like to note the difference between too much growth, not enough growth, or trauma, and we're talking about too much growth here. And our etiology is going to be very similar. It's going to be states with really high estrogen, so PCOS, estrogen supplementation, nulliparity, late menopause, or estrogen producing tumors. These are all going to predispose a patient to developing endometrial hyperplasia. And in terms of our presentation, this is usually going to be postmenopausal bleeding. Remember, all bleeding postmenopause is considered abnormal, but if we were to have a premenopausal patient, we could have any type of abnormal uterine bleeding. So this is going to be bleeding that is not expected. This is going to be bleeding outside of the normal menstrual cycle. In terms of our diagnostics, this is going to be where the high yield part comes in. In adenomyosis, we were talking about the physical exam findings, but in endometrial hyperplasia, it's going to be all about the histology. And what is that histology going to sound like on exam day? It's going to sound like proliferation of glandular cells with atypical cells showing extensive loss of cell polarity. Those are all going to be hot words describing our endometrial glandular hyperplasia here. In terms of our management, we can use progesterone supplementation like progestin because this is going to combat the growth causing effects of estrogen. So if we give them progesterone, it's going to combat and kind of rebalance out that hormonal balance that we talked about a lot in our videos on the menstrual cycle. We can also move to hysterectomy if there's evidence of cellular atypia that is concerning for malignancy. Finally, let's talk about our Asherman syndrome, and I'm going to switch back to our blue color because we are back to talking about the basalis layer. And essentially in Asherman syndrome, we are going to expect some type of uterine trauma, and the uterine trauma is going to lead to destruction of our endometrial basalis layer, and this trauma is going to be replaced with adhesions, scarring, and fibrosis, and this is going to lead to failure of regeneration of our endometrial tissue. And so I'm going to go ahead and highlight here again over uterine trauma with red because we talked about trauma as being our red color here for describing the primary insult. So you can imagine here, if we go back to our drawing, that if we were to like do some red lines here to show some trauma from perhaps a uterine curettage or dilation and curettage procedure, that is going to have difficulty regrowing here, and that's what Asherman syndrome is. And so if we have trouble regrowing our endometrial tissue, we're going to expect a patient who presents with amenorrhea because they cannot regrow their endometrial lining, so it's impossible to have a menses if that's the case. We can also expect infertility or abnormal uterine bleeding because you can imagine if one portion of the endometrium is growing but the other one is not, this might cause some abnormal bleeding at mid-month or something like that. We can also expect pelvic pain because there's scarring and fibrosis here, and also recurrent pregnancy loss because we are not generating a full, well-working endometrial lining. So really the thing to be focusing on in terms of Asherman syndrome is all about this prior uterine trauma. So some description of a uterine surgery or a miscarriage or an ectopic pregnancy where they had to go in and do something surgical that is changing the lining of the uterus and predisposing a patient to scarring is what we're worried about with Asherman syndrome. So in terms of our high yield review, it's really important to know our layers of our uterine lining. Are we talking about the functionalis, the basalis, or the myometrium? And then it's important to know if we're talking about hyperplasia, like in the case of adenomyosis and endometrial hyperplasia, or are we talking about trauma, like the case of Asherman syndrome? Once we have that down, it's important to nail down some hard-hitting facts. So in the terms of adenomyosis, it's all about this physical exam description of this boggy, uniformly enlarged globular uterus that's going to be really high yield. And then in terms of our endometrial hyperplasia, we're going to expect proliferation of our glandular cells as a really high yield point. And then for Asherman syndrome, we're looking for that trauma. So some history of some sort of uterine surgery or curettage, that's going to point you towards our Asherman syndrome. So I hope this video was helpful for you guys. Can't wait to see you guys in the next one. Bye! All right, let's continue talking about the rest of our uterine pathology. On this slide, we're going to be talking about our endometriosis and our postpartum endometritis. And a way to think about this is endometriosis is going to be uterine tissue in places where it's not supposed to be. And in postpartum endometritis, we're going to have tissue inside the uterus that is no longer supposed to be there. So that's why I want you guys to be framing these two different pathologies. So let's get started talking about our endometriosis. And when it comes to endometriosis, I want you guys to think about uterine tissue that is not in the proper place. So if we look over here in our diagram of the uterus, we expect our uterine tissue to be lining here in the uterine cavity where I drew this triangle. However, in endometriosis, we can get uterine tissue out here, like along the intestines, or on the dome of the uterus, over here on the ovaries, or the fallopian tube. Just about anywhere in the pelvic region, we can have migration of this endometrial tissue. And this usually migrates along the path of venous return, which I'm representing with this blue line. And also it can migrate with this lymphatic return, which I'm drawing in our green here. So that is going to be the route on which this endometrial tissue kind of moves to other portions of the pelvic region where it can start to cause pathology. So let's kind of review. We have extrauterine endometrial tissue. That is the definition here. It is uterine tissue outside of the uterine cavity. The ovaries are going to be our most common site, but we can also see it at the uterosacral ligaments, the rectouterine pouch, parts of the peritoneum, essentially all of these regions of the pelvic area. And we talked about the fact that it's going to be retrograde blood or lymphatic flow that is going to cause this spread. And we can also see metaplastic change of multipotent cells. So we can start to see this uterine tissue undergoing changes if it has been there for a long time or under the exposure of a lot of estrogen. Those are two risk factors. So in terms of our etiology and risk factors, it's going to be most common in our reproductive age females. And especially if they have a family history of endometriosis, that's going to put them at a higher risk. And then things like nulliparity and early menarche are also going to be risk factors, because we know that both of these are going to result in increased estrogen levels. And we know that these tissues are going to be estrogen sensitive. So if you have endometrial tissue that is moving out of the pelvic region and then you have estrogen exposure that is making it grow, we are going to expect worse endometriosis. So how will a typical patient present here? A classic vignette is going to be a patient that is usually going to be in a wide age range. It could be anywhere from the 30s up into the 50s, who's going to be complaining of abnormal uterine bleeding, perhaps some pelvic pain. It can be really nondescript because we can have endometriosis in just about any area of the pelvis. So we can have things like dysmenorrhea, dyspareunia, we can have dyschezia, as well as cyclic pelvic pain. And the reason why it's cyclic is because if this patient is still menstruating, it's going to be sensitive to the changes in estrogen throughout the menstrual cycle. We can also see patients with infertility, because if we have growth of endometrial tissue on the area of the fallopian tube or the ovaries, this can inhibit ovulation or traveling of a fertilized zygote into the uterine pouch. We can also see abnormal uterine bleeding, and we can see nodular adnexa if we get really big growths of endometriosis on the ovaries or the fallopian tube. And then oftentimes the uterus will be described as a retroverted uterus, and that's because normally our uterus is anteroverted, so it's kind of facing forward, as we have showing here in this diagram. In a uterus with endometriosis, it can oftentimes kind of flip around, and I'll draw that for you guys to kind of look retroverted, so it'll kind of be pushing back in this direction here, and that's a common physical description of a patient with endometriosis. In terms of our diagnostics, this can be visualized on ultrasound, especially if we have really big lesions, and it can help us identify where this endometriosis is causing problems. And then if we were to look at surgical pathology, there's some high yield words here when it comes to describing this endometriosis. So we can have yellow brown powder burn lesions, and I had no idea what powder burn was, but apparently powder burn is when you have like an old-fashioned gun and it shoots and like the gunpowder like burns things on its way out. That's what powder burn looks like, which was a new thing for me. And so this is an example of that powder burn lesion here. You can see it's kind of like this yellow, gray, dusty gold color, and that's going to be when the peritoneum gets endometriosis, as opposed to our other lesion, which is going to be an endometrioma, and this is going to be a blood-filled cyst on the ovarian tissue, and it's composed of endometrium, and so we call this a chocolate cyst. And so if we were to look here at our ovary, you can see a cool example of chocolate cystic structure right there, and you can see that this is pointing to what would be the ovary in our overarching diagram of the pelvis, whereas the peritoneum would be out here lining the pelvic structures. In terms of managing our endometriosis, it's going to depend on how severe the symptoms are. We can treat this symptomatically by just giving patients NSAIDs, or we can actually go to the root of the problem and we can kind of try and tackle the hyperestrogenergic state that may be making this worse. And we would use things like OCPs, GnRH agonists, progestin, or danazol here. So all these green things that I'm highlighting would be trying to reset that estrogen balance in the body. And then we can also manage this with surgical removal if it was causing big problems with pain or infertility and we needed to change that architecture surgically. Now I want to move on to talking about postpartum endometritis, and this is exactly what it sounds like. It's going to be inflammation of the endometrium, usually after delivery or some type of manipulation of the cervix or uterine cavity. And so essentially I'm going to draw a picture here fresh for you guys. Let me erase our old retroverted uterus and let's replace this with a chunk of tissue up here in the uterus. And this chunk of tissue is going to have these little green spikes on it, and that is going to represent infection, because usually this postpartum endometritis is accompanied by infection. And so essentially what is happening here is we have retained uterine contents. So this could be placental tissue, this could be an IUD, this could be perhaps fetal parts from a molar pregnancy or something like that, and it's going to going to cause inflammation, and this inflammation can be accompanied by infection of our endometrial lining, which I was demonstrating with these green guys all over our endometrial tissue or our placental tissue. And essentially this is going to happen in our reproductive age women with some sort of recent manipulation of the uterus or cervix. So we're thinking like delivery of a baby, or maybe an IUD insertion or removal, or perhaps a uterine dilation and cuttage procedure. Something like that is going to be causing this abnormal finding in our endometrium. Also, multiple cervical exams. So if you're poking around in the uterine cavity and introducing instruments in there that could seed bacteria, this could be another risk factor for causing our endometritis. But it's going to most commonly in a vignette be a patient who had a delivery and supposedly delivered all of the placenta, but then maybe hours or days later they're starting to complain of like blood continuing to come from the vaginal orifice, perhaps some pelvic pain that is out of proportion to what would be expected post-delivery, and then they're going to start getting things like fever and signs of like infection, and this can actually progress to be pretty bad disease. So we can expect postpartum sepsis or a surgical site infection or a peritonitis if this gets really out of hand. And so you kind of be looking for a progression of symptoms. We'll probably start with fever and vaginal discharge and abdominal pain, but this could get really, really bad. So we can start seeing like extreme uterine tenderness and perhaps foul-smelling lochia. That would be evidence that this would be infection that has gone beyond simple inflammation. In terms of the bugs that usually cause this, in the terms of the acute infection, it's usually going to be group B strep that is causing our postpartum endometritis. And this makes sense, right? We prophylax our mothers against group B strep if they are carriers of this, because we know that this is a common complication of pregnancy and pediatric disease. However, we can also have chronic, and this is going to be due to growth of gonorrhea or actinomyces israeli. And we're going to see evidence of plasma cells on endometrial histology. That's going to be a pretty high yield fact, and this makes sense, right? Because we know that plasma cells are going to be more of a chronic immune response, whereas an acute infection you might expect like a real big bump in neutrophils on our CBC. So that would be another way that they might show you on lab values to differentiate these two. In terms of our management here, we're going to give clindamycin as well as gentamicin plus or minus ampicillin. So that ampicillin is going to be effective against our actinomyces or group B strep infections. However, we're going to need that clindamycin gentamicin combo for all the other suspects that we could be expecting, and that's why we usually treat these patients with a more broad spectrum management plan. So in terms of our high yield review, remember that endometriosis is all about uterine tissue that is not in the uterus. So we expect extrauterine endometrial tissue. It's going to be our ovaries that are going to be the most common place. And when it comes to ovaries, we're on the lookout for things like chocolate cysts. If it's on the peritoneum, we can expect powder burn lesions. And it's important to remember that this tissue is estrogen sensitive, so it's going to be responding to changes in estrogen, either in high estrogen states or in response to the menstrual cycle. And we also talked about postpartum endometritis, which is going to be most common in a patient who has just delivered a baby, but we can also expect things like IUD insertion or removal or any type of uterine manipulation, and this is going to present with signs of a infected uterus. So we're going to expect things like foul-smelling lochia, abdominal pain, and fever, signs that we have an infection here. We talked about some of our common bugs, and then we talked about the fact that we need to treat this with antibiotics. I hope you guys enjoyed this video. I can't wait to see you guys in the next one. Bye! Alright guys, let's get busy talking about uterine cancer. When it comes to uterine cancer, we can have our cancers either in the endometrial lining, which I'm going to be outlining here in pink, and we can also have our cancers that are going to be localized to the muscularis layer, which is out here in the uterine myometrium. So you can see that these would be cancers of the muscle, whereas the other cancers would be cancers of the endometrial lining. So let's go ahead and get into it. Let's start by talking about cancers of our endometrial lining, specifically endometrial carcinoma. And essentially what's happening here in endometrial carcinoma is it's going to largely affect postmenopausal women who've had a long exposure of estrogen. And so this prolonged estrogen exposure is going to lead to endometrial transformation. We know that endometrial tissues are really sensitive to estrogen. It causes them to grow and be active. And so after prolonged years of estrogen exposure, this can actually lead to transformation into cancer. And so if we think about it, it's going to be our postmenopausal postmenopausal women with a history of estrogen exposure. And there's a lot of things that can cause estrogen exposure. We'll talk about a few. So patients who are obese are going to have increased peripheral estrogen creation. Patients with PCOS are classically in a prolonged estrogenic state. And then late menopause means you have more years with a menstrual cycle. And we know that menstrual cycles have periods of high estrogen. And then also nulliparity. If you've never been pregnant, you've never had that 9 months of your life where your body is dominated by progesterone, and therefore your body was being dominated by estrogen at that time point. So all of these estrogenergic states are going to lead you to have a higher risk for endometrial cancer. And so this is classically going to present as abnormal uterine bleeding. And when we think about postmenopausal women, all bleeding from the vaginal orifice is going to be abnormal because these women have stopped menstruating. And so if we see bleeding in a postmenopausal woman, we need to have uterine cancer on our differential. So how are we going to identify these uterine cancers? It's going to be all about biopsy. So we're going to be talking about two different types. So in green, I'm going to be talking about the endometrioid type, and then in blue, we're going to be talking about the serous type. So let's go ahead and take a look at some of this histology here, starting with endometrioid type. This is going to be the type that's really going to be common in people who had increased estrogen exposure. So this unopposed estrogen exposure plus some sort of molecular cancer derangement, for example, P10 or mismatch repair protein loss, are going to be big ones for endometrial cancer. And together, these two factors are going to lead to transformation. And we expect to see on histology abnormally arranged endometrial cells. So let's go ahead and zoom in and take a look at this. Here we would see an example of what would be normal looking endometrial tissue, and then you see we have like these areas here where we have a lot of purple mitotic activity and this loss of organization. So what I'm pointing to with my arrow here would be the area where we would expect to see the endometrial cancer. And so I just wanted to point that out, but let's also compare it to our serous type. So this is going to be due to endometrial atrophy, and we know that the endometrium is going to atrophy in our postmenopausal patients. And eventually this is going to lead to transformation, and this type tends to be very aggressive. And so on the histology for these, you're going to see papillae and tufts plus or minus psammoma bodies. So let's go ahead and take a look here. In terms of our psammoma bodies, these are going to be these beautiful concentric circular rings of calcium deposits. They're really easy to spot, and these are going to be easy points. And so this would be a great way to differentiate two different types of endometrial cancer if you were given a biopsy on test day. Let's move on now to talking about our endometrial or uterine polyps, and essentially these are going to be really similar to endometrial cancer. However, they are much smaller and they're going to be benign. So just like in our endometrial cancer, this is all about prolonged estrogen exposure, and this estrogen exposure is basically going to lead to little tufts or clumps of endometrial tissue that has grown and just kind of solidified in one spot of the uterus, and it's going to be described as a discrete collection of benign endometrial tissue. And this is going to present the same. It's going to be a postmenopausal patient with abnormal uterine bleeding, and so if you get in there and do the biopsy, you're going to see a small localized discrete patch of tissue, and the tissue is going to be just like normal endometrial tissue that has all clumped up. There's going to be no transformation, no signs of malignancy in terms of like high mitotic activity or disorganized endometrial tissue. And so we're just really going to manage this symptomatically. So if these need to be removed surgically, we can do that, or we can just treat these patients with supportive care. But just to go over our etiology again, this is going to be the postmenopausal women with history of estrogen exposure presenting with abnormal uterine bleeding, and we're going to have normal histology findings in this case, similar to the histology that we talked about here in the normal appearing endometrial tissue. Let's move on now to talking about our leiomyoma, also called fibroids. Fibroids are a really common name for this. Leiomyoma is a bit difficult to say, so you will usually hear this as fibroids on exam. And these are also going to be estrogen sensitive tissues. However, we are now talking about growth of the myometrium. So if you remember in the beginning, I talked about this pink area here in our uterus as being the endometrial lining, and then this orange layer being the muscularis layer. And so now we're talking about cancers in the muscular part of the uterus as opposed to the endometrial part of the uterus. And essentially this is going to be a benign smooth muscle tumor, and so there is no chance of malignancy here with fibroids. However, it doesn't mean that they're without pathology or without bothersome problems. And so a classic patient vignette here for fibroids would be a 31-year-old black patient who is showing showing up with abnormal uterine bleeding. Perhaps they're bleeding a lot between periods, and this could be heavy bleeding. It could be painful bleeding. They might have things like constipation or recurrent pregnancy loss or just inability to get pregnant in the first place. These are going to be a common presentation of a patient with fibroids. And then you go to do a physical exam, and the classic physical exam finding is going to be an enlarged, asymmetric, non-tender uterus, and we will explain why this physical exam finding is the way it is. Let's kind of take a look at one of these images here, and you'll see that in this image I have here of this gross pathology, these are discrete muscular tumors, right? And you can see in this larger picture we have these discrete blobs of muscular tumor all throughout the uterus. And if you were to feel this with your hands, it would feel like this irregularly shaped uterus that's not particularly painful on physical exam because it's just benign muscle tissue, and it's going to be asymmetric. That's the key here, as opposed to adenomyosis, which we usually think of as a globular, symmetric, enlarged uterus. So that's going to be a high yield finding here. And then in terms of our epidemiology, we talked about the fact that this is going to be females 20 to 40 years old, and usually in question stems, they like to mention that there's an increased incidence in our Black patients. And then in terms of our complaints, I talked about a few in our vignette, but let's go over them all. We can have abnormal uterine bleeding. Sometimes this will sneak into a question as a microcytic anemia, for example, iron deficiency anemia, due to really heavy periods from these fibroids. And then we can have pelvic pain, miscarriage, urinary frequency, and constipation. And this urinary frequency and constipation is because we know our ureters and our rectum are really close to our uterine cavity. And so if we get these big muscular masses pushing on other architecture around, they're going to lead to urinary or bowel symptoms. And that's why these patients can oftentimes present with that. In terms of our histology, let's take a look here. We're going to get this description here of these benign, smooth muscle bundles. And you can see that it's fairly well organized. There doesn't appear to be any mitotic activity here. And it's going to be described as multiple discrete tumors displaying this whorled, well-demarcated, smooth muscle bundles. And you can see here that if we were to look at this on gross pathology, you see that they have these well-defined, discrete muscular tumors all throughout the uterus, and this is going to be how it presents on test day. And classically, what I would imagine a test writer would want to do is imagine they put 3 dots on a diagram of a uterus. Well, let's make it actually 4 dots and say, okay, here we go. And then they said, all right, this is A, B, C, and D, and they're asking you, all right, where are we going to expect to find a fibroid if we were to go in and take a biopsy? And they're testing your ability to identify that in here around C is going to be endometrial cancer territory. Out here in A is going to be ovarian cancer territory. Up here in D is going to be cervical or vaginal territory, right? So they want you to be able to know that this irregularly enlarged uterus is due to all this bumpiness out here in the area dominated by B. And this is going to be how they're going to ask about fibroids on exam day. They really like you to know that fibroids cause this irregular shape because they're just so big and obtrusive, and that's like the key to their pathophysiology. Now let's move on to talking about leiomyosarcoma, which is like a relative of fibroids, but they actually don't come from fibroids. They are actually their own thing, and so they're going to be a malignant neoplasm of the myometrium. So we are still talking about the muscular portion of the uterus, but these are not arising from fibroids, and that's really important. So I'm going to highlight it in a separate color. These do not transform from leiomyoma, and I'm going to highlight it again up in the fibroid section. These do not transform into leiomyosarcoma, and that's important because these both have really similar sounding names. In fibroids, it's called leiomyoma, and then in the leiomyosarcoma, it's just a slight change in the language of these two disease processes, but in their level of prognosis, leiomyosarcoma is so aggressive and so lethal. And so it's important to be able to differentiate these on test day. So when it comes to test day and leiomyosarcoma, they're going to talk about the fact that this is going to be way more common in our postmenopausal females, whereas our fibroids were classically going to be premenopausal females. And then if we were to get histology, we would see a single tumor displaying areas of necrosis, whereas if we talked about the histology of our fibroids, which is what you're most likely to see on exam day, it would be this well-organized whorled pattern without any mitotic activity or signs of transformation transformation or penetration of basement membrane, nothing concerning like that. So that's going to be how you're going to differentiate these two on exam day. In terms of our high yield review, it's important to note that all of these tumors are going to be related to increased estrogen exposure, but it's important to know that endometrial carcinoma and uterine polyps are going to be in the endometrial lining, whereas our leiomyoma are going to be out in the muscular region. When it comes to presentation, we expect uterine cancer to be in our postmenopausal females, whereas fibroids are going to be in our premenopausal females, especially those presenting with abnormal uterine bleeding and things like constipation and urinary complaints and miscarriages. Additionally, the histology is going to be important. We expect muscular looking histology in fibroids, whereas we're going to expect endometrial type histology in our endometrial cancers. And when it comes to our description of the uterus for fibroids, it's going to be super high yield to know that this is going to be an asymmetrically enlarged uterus. You can appreciate this here with this gross specimen that is just super bumpy and irregular. And then it's important to know that leiomyosarcomas do not come from fibroids. They are extremely aggressive and they're going to be described as central areas of necrosis on histology, and it's important to know that the prognosis for these is very poor. I hope you guys enjoyed this video. I can't wait to see you guys in the next one. Bye! Alright guys, let's get busy talking about our ovarian cysts. We're going to have 3 types of ovarian cysts to talk about, and then towards the end we are going to talk about a couple of complications of ovarian cysts. So let's go ahead and get started by talking about our follicular cysts. And follicular cysts are going to happen when we have development of the Graafian follicle that kind of goes awry. So we know that during normal menstrual cycles we have our immature egg, and as it matures through this cycle over approximately 14 or 15 days, it produces estrogen, it produces some zona pellucida in the form of fluid, and then around day 14 we have this egg that pops out and is ready for ovulation. What can occur in our cysts is that we have failure of this rupture of this Graafian follicle, and instead fluid just continues to accumulate. So if we review this pathophysiology, it's going to be failure of our Graafian follicle to rupture, and I want to remind you guys that a predominant part of this Graafian follicle is going to be our granulosa cells, and these are going to be the cells that are going to be responsible for this cystic fluid accumulation. So you can imagine that you're going to have a large cyst, probably about this big in comparison, because we never get this rupture. And if we were to look at this on ultrasound, this cyst would look like this here on our ultrasound. And so if we zoom back out, we can talk about some of the associations of these follicular cysts. These follicular cysts are associated with an increased estrogen state, and this makes sense, right? Because along this journey, as the egg is growing up into the Graafian follicle, it is also promoting endometrial growth, right? So if we were to kind of trace endometrial growth, it would be low, and then it would start getting bigger and bigger and bigger and bigger and bigger as we had more and more estrogen produced. So it totally makes sense that if we look at our associations, an increased estrogen state is going to lead to endometrial hyperplasia. And this all ties into the pathophysiology of our follicular cysts. And so it's going to be the most common mass in our young females. And then another thing is that this is the pathophysiology of polycystic ovarian syndrome. And we know that in polycystic ovarian syndrome, we're going to expect a patient that presents with a classic syndrome of obesity, acanthosis nigricans, acne, and hirsutism. And this is all due to the hormonal imbalance where we have excess of estrogen and we are not making it to this corpus luteum stage where we expect progesterone. Let's contrast this now to our theca lutein cysts. So you will remember that I mentioned that our Graafian follicle is composed largely of granulosa cells. However, we also have theca interna cells. And so if we were to zoom in here to our ovary, we would see that our granulosa cells would be a cuboidal epithelium here more towards the center, whereas our theca interna cells are going to be a squamous type cell out here on the periphery. However, they are also capable of producing fluid. And so essentially these are both going to be fluid heavy cystic structures, but the pathophysiology is a little different. So in our theca lutein cysts, it's going to be increased beta HCG, which we know is a hormone of pregnancy. It's going to lead to stimulation of these theca interna cells, and they're going to lead to bilateral cyst formation. It's important here, theca lutein cysts tend to have a predisposition to becoming bilateral. They tend to present that way more than a simple follicular cyst would. And if we look at the etiology here, it's going to be things where we have increased levels of beta HCG. So choriocarcinoma trauma or molar pregnancy are both two pathologies where we have huge increases in beta HCG, and this is going to lead to our thecal lutein cysts, and these should resolve after our beta HCG levels normalize. So I'm going to draw another circle here around this follicle, but this time in pink, and this is how a thecal lutein cyst would appear. So if we were to look at it on our ovary, it would be this little pink circle here. These are both going to be fluid-filled cystic-like structures that you could visualize on ultrasound. Now let's contrast this to our next pathology, which is going to be our chocolate cysts. And chocolate cysts are different. Whereas previously we were talking about inherent ovarian problems, our chocolate cysts are going to be migration of endometriosis, which we know starts here in the uterus, where I'm highlighting in brown, and essentially this uterine tissue is going to migrate out and it's going to land on our ovary. And so you can expect that we would have a cyst closer here to the periphery of the ovary that is just growing and growing and growing, and we call these chocolate cysts because they look like chocolate on gross exam specimen. And so if we review our pathophys here, this is endometriosis localized to the ovary, and we expect the woman to have underlying endometriosis that perhaps is not just located in the ovary. So in underlying endometriosis, we can expect a premenopausal female usually who's going to present with pelvic pain and dyschezia and perhaps dyspareunia, and this is all going to depend on where the endometrial tissue has landed. And so in some cases, let's say it's in an ovary, this is going to be a chocolate cyst. This would probably present with adnexal type pain because that's where the endometriosis migrated to. Let's move on now to talking about some of the complications of our cysts, the first being ovarian cyst rupture. So in terms of these really fluid heavy cysts that we talked about here in green and pink, these fluid collections up here are going to have the ability to burst open, and when they burst open it can be quite painful. And so this is going to present as lower quadrant abdominal pain, usually going to be unilateral if one cyst just bursts open on one side, and this can also be accompanied by bleeding. And so on an ultrasound you would expect to see a collection of fluid in the rectouterine pouch because that is where adnexal fluid drains to. Now you could also see blood here because when we have rupture of this follicular cyst or this thecal lutein cyst, we can have exposure of blood vessels with that rupturing pathology, and they can bleed out a little before hemostasis is obtained. Now when it comes to the chocolate cysts, these can also rupture or be disturbed, but they're less likely to leak fluid, and I would say they're more likely to be leaking blood because they don't really have a lot of fluid. They are more of like extra uterine tissue, so the chocolate cysts tend to be a little more firm, whereas the follicular cysts and the thecal lutein cysts tend to be more fluid composed. Now let's move on to talk about ovarian torsion, which is going to be a really high yield surgical emergency. So in ovarian torsion, what's happening is we have twisting of our ovary and our fallopian tube around the infundibulopelvic ligament or the ovarian ligament, and this is going to lead to compression of ovarian vessels. So let's go ahead and orient ourselves to some of this important anatomy here by zooming in and doing some labeling. So here I'm going to draw in our infundibulopelvic ligament here, which is also called the suspensory ligament, and this is going to carry blood supply from the aorta via the gonadal artery, and it's also going to carry lymphatic supply as well. And then if we label this structure here, this is going to be our ovarian ligament here, which is not that special. It doesn't really even contain blood supply or anything. It's just there providing support. And then here we have our fallopian tube, and then we can also draw in some collateral blood supply from our uterine artery, which is also going to help supply the ovary with blood. Now what happens here is we can get twisting all up in this area, and when this twisting occurs, we are essentially clamping down on a lot of vessel structures. So what happens if we clamp down on this structure here, the suspensory ligament? Essentially we are going to be cutting off blood supply right here and also cutting off return of lymphatic drainage. And so with the cutting off of blood supply, this can result in ischemia, and with the cutting off of the lymphatic drainage as well as our venous drainage, we're going to be unable to have return of that fluid, and so it's going to present with edema in the ovary. So we're getting two things happening here. We're getting lack of arterial blood flow, and then we're getting backup of edema back into the ovary. Luckily, we have some collateral from the uterine arteries, but these can sometimes also be tied up depending on how the ovary flips in space, and so it's not always guaranteed that we're we're going to have collateral blood flow. So this is always going to be a surgical emergency. We're super worried about this ovary not getting enough blood supply and dying and resulting in infertility or an acute abdomen. So if we zoom out, let's kind of review some of the things that are going on here. We're going to have venous as well as lymphatic compression here, which is going to lead to our edema, and then we can have arterial compression, which can lead to ischemia and necrosis. And we mentioned that the ovary does have dual blood supply from the ovarian and uterine arteries. However, we still are very concerned for necrosis and ischemia in this ovary, and this needs to be managed immediately and surgically. And this is going to present with acute onset unilateral abdominal pain. A classic vignette is going to be a patient who's outside shoveling snow and like lifting heavy things, and when they like grunt really hard, they're going to flip that ovary, and then all of a sudden they're going to get this increasing abdominal pain on a really acute timeline, and this is because their ovary is getting starved for blood. And now you might be asking me, Jake, I get it, this is going to be lower quadrant abdominal pain, but you said the same thing for our ovarian cyst rupture, and that is a fantastic point. And so what's going to help you determine whether it's this or that is going to be our ultrasound. So if we were to ultrasound an ovarian cyst rupture, we would probably see a cystic looking ovary, and we could see some cystic fluid or blood in the rectouterine pouch. However, if we were to get an ultrasound of ovarian torsion, if we were to put some Doppler effect on that ultrasound, which shows flow of blood back and forth, we would see absence of blood flow here in the area leading up to the ovary, and we would also probably see an ovary with massive edema because we don't have that backflow of lymphatics and venous back upwards towards the inferior vena cava and thoracic duct. So you're going to see two very distinctly different ultrasounds in these two pathologies that could be presenting with acute lower quadrant unilateral abdominal pain. So really rely on ultrasound findings and history here in order to help you guys secure this differential. So in terms of our high yield review, we talked about our follicular and theca-lutein cysts both being heavily dominated by fluid filled structures. It's going to be granulosa cells in our follicular cysts and our theca interna cells in our theca-lutein cysts. Remember that the granulosa cells are going to be all associated with estrogen, whereas theca-lutein is going to be associated with beta-HCG. Our chocolate cysts, on the other hand, are going to be tissue that has migrated from the uterus, and it tends to be less fluid-like and more solid tissue-like, and it's classically going to be described as a brown chocolate cyst. And then we talked about what happens with ovarian cyst rupture, how we're going to get collection of fluid in the rectouterine pouch on ultrasound, and how this is exceptionally important for our differential. And then in ovarian torsion, we talked about the interesting anatomy here. It's important that you have the names of these ligaments down and which ones carry blood supply and which ones do not. And it's important to note that the edema is due to failure of backflow, whereas the ischemia is due to the compression of the arterial flow, and that this is going to be a surgical emergency in terms of our unilateral abdominal pain, and this will be identified on ultrasound as an absence of flow on Doppler, as well as an ovary with edema. So I really hope you guys enjoyed this video. I can't wait to see you guys in the next one. Bye! Alright guys, let's get busy talking about our cervical pathology, and we're going to largely be talking about our cervical dysplasia spectrum. And so let's first talk about the cellular architecture of our cervix in order to orient ourselves to what is happening here in this spectrum of dysplasia. So if we were to zoom in here to our cervix, we're going to see that the cervix is characterized by these squamous epithelial cells here on the outside that I'm drawing in orange, and then as we move in closer to the uterus, this starts to turn into a columnar glandular epithelium, which I am denoting with these square block-like cells in light blue. Now this area has a special name, and it is called the transformation zone, which I'm kind of denoting with this pink star, and it's incredibly special because it is very susceptible to malignant change, and this is because this is a change between squamous and columnar, and so this can lead to the production of cancers in this area. And so our cervical area is very susceptible to cancer, and namely it's going to be largely caused by HPV infection. Now HPV stands for human papillomavirus. This is a virus that is ubiquitous, and most young people are exposed to it through sexual encounters, and so HPV infection are going to lead to disordered epithelial growth at the transformation zone. And remember, we denoted our transformation zone with this little pink star. It's going to be a really high yield phrase when it comes to cervical pathology. And this transformation zone can continue to progress to more and more progressive malignancy. And so there's some special words and nomenclature that they use with respect to this transformation zone. So in terms of this disordered growth, it can move through 3 stages: CIN1, CIN2, and CIN3. And this can end with invasive squamous cell carcinoma. So let's go ahead and take a look here at this diagram. And so you'll see we have normal tissue here, and you'll note that we have our squamous type cells, which I'm kind of denoting in orange here. And then these squamous cells are going to continue over here. And then in light blue, we have our columnar cells over here. And so this is the transformation zone all up in this area with my big pink star. I'm going to clear this pink star so we can get a little more granular. In CIN1, we start to see some abnormal cells start to form, and this is going to progress through CIN2, CIN3, and in CIN3 and invasive carcinoma, we're going to start to see a lot of like abnormal mitotic activity. So you would expect to see a lot of pink and purple mitotic activity here. And then when it comes to invasive carcinoma stage, this is characterized by breakage through the basement membrane. In terms of being able to differentiate CIN1, 2, 3 from invasive carcinoma based on the cellular characteristics, that is not a task you're expected to be able to do on the step 1 exam. However, I would note it's important to be able to note that breakage through the basement membrane is going to be characteristic of invasive carcinoma. That's going to be something that you would be expected to do on exam day. So when it comes to our etiology, we talked about the fact that it's HPV exposure that is going to be the most common cause of our cervical cancers. However, there are some other minor risk factors that we can talk about, such as multiple partners, because we know that HPV is spread through sex, and then smoking, because we know that smoking leads to carcinogenic change throughout the body, but this is particularly high yield in cervical cancer. And then DES exposure, I usually characterize as being associated with clear cell adenocarcinoma in the top 2/3 of the vagina. However, there's a loose association with cervical cancer as well, but I would like you guys to be thinking primarily about DES as exposure for vaginal cancer, especially the top 2/3 of the vagina. And then immunocompromised states also are going to lead to cervical cancer. And this is because the immune system can keep our HPV infection at bay and kind of keep it a little bit silent and soft. Whereas if we are in an immunocompromised state like HIV/AIDS or on immunocompromising medications, our HPV can work a lot faster and change that transformation zone a lot faster, leading to cervical cancer much more quickly. And so when we think of our presentation of cervical cancer, there's not a lot that pops out to me in terms of presentation. Perhaps the one complaint we can see is vaginal bleeding after intercourse, because the cervix can become friable, and then if this is irritated during intercourse, it can bleed a little bit. But in reality, most cervical cancer is going to be asymptomatic for a long time, and it's going to be identified on routine screening. So we start to see abnormal cells on our routine pap smear screens. And what is a pap smear, you might ask? And so a pap smear, which I'm going to highlight with this orange little stylet or Q-tip, is a little probe that we put into the cervical transformation zone. So we go ahead and insert this probe up into the vagina, and then we put it right here in the cervix, and we brush it a little bit, and we get some cells there because we know that this is the area that is most likely to have cancer. And we look at these cells under the microscope, and we're looking to see if there is any abnormal growth here in the cervical transformation zone. And so what we expect to see if we do see transformation is something called coilocytes. So on our histology, we see coilocytes, which are pathognomonic for HPV infected cells. And for those of you who don't know, pathognomonic essentially means that this cellular finding is unique to HPV infection. So it's a great way to get easy points on exam day. These are described as a racinoid nucleus with a perinuclear halo. Let's go ahead and take a closer look here. I love this histology. I'm obsessed with it because I think they look like koi in a koi pond, like decorative koi. So I always imagine these as like a fish with these big bulging eyes from the perinuclear halo and the racinoid nucleus. And the fact that they are called coilocytes helps me remind that they also look like koi, and they just look so distinct on exam day, and this really helps me get questions right related to HPV. However, I want to mention one thing, and that there is a common similar looking cell type in a vaginal or cervical complaint, and that's going to be clue cells. So let's take a look at clue cells here, and these are going to be secondary to Gardnerella infection, and you'll see they look really similar in the fact that they kind of have this like bluish gray stain, and they have what can kind of look like a racinoid nucleus. However, it's going to be all about history here in differentiating. So in a Gardnerella infection, you're going to expect like a gray or fishy-like exudate coming from a vaginal orifice, and that's going to be usually in the setting of multiple recent partners, and you're going to see these clue cells, to me, which seem a little more like granular, like they see like they have like kind of gray and like tissue paper. They're often described like crumpled paper, whereas our coilocytes don't really have that crumpled paper appearance quite as much. You can see that they look similar, so I don't want you guys to be looking for a pathognomonic cell and being like, oh my god, that's definitely a coilocyte, when it's actually a clue cell. So be sure you be able to differentiate these two based on appearance and also history, looking for that gray fishy odor in the setting of our clue cells from Gardnerella infection, whereas HPV exposure, pap smear in our patients with cervical cancer. So now that we talked a little bit about the histology, let's talk about our microbiology. So in terms of our microbiology, this is, like we said, associated with HPV, and the strains they really like you to know on exam day are 16, 18, 31, and 33. That is really high yield to know. I would say especially high yield is going to be strain 16 and strain 18. So they like you to know more granular detail about 16 and 18. Specifically for 16, they want you to know that this expresses the E6 gene protein, and this is going to lead to inactivation of P53. And we know that P53 is a protein that's responsible for inducing apoptosis in abnormal cells. And so if this is not happening, these abnormal cells are going to have a party and just grow out of control. And then in our HPV strain 18, this is going to express the E7 gene protein, and this is going to lead to inactivation of RB, which we know has a similar function in the term that is a tumor suppressor gene. And if it is not present, then we're going to have uncontrolled growth of abnormal cells. So let's imagine these cells are just growing and growing and growing, and nothing is keeping them in check. What's going to happen eventually when we get down to our invasive carcinoma? The classic presenting feature of invasive carcinoma is going to be urinary complaints. So the invasive carcinoma can obstruct our ureters, and this is going to present with hematuria and hydronephrosis and renal failure. So you may see bumps in creatinine on lab values, or perhaps red blood cells in a urinalysis, or difficulty with emptying the bladder. These are all going to be presenting complaints of an invasive carcinoma, and these are patients who perhaps didn't get screening with pap smears, and so they're presenting with end-stage disease, and this is how it will classically present. So we talked about our management in terms of routine pap smears, and this is to catch this disease process before it becomes invasive. And then test writers also like to ask about relative frequency, and so I want you guys to know that endometrial is more common than ovarian, which is more common than cervical, and so that's going to be another important high yield thing on test day. I also want to point out that since this is a squamous cell carcinoma, we can expect keratin pearls, but squamous cell carcinomas can happen independent of HPV infection, and they can also happen outside of the cervix. So it's important to know that just because you see keratin pearls does not mean this is a cervical cancer. However, you can rely on things like coilocytes to be like, that is a more specific finding for cervical cancer. This squamous keratin pearl type pathology can apply to many cancers across the body, and so I just wanted to differentiate those histologies for you guys. Lastly, let's go ahead and talk about cervicitis, which we will cover a lot more in depth in our infectious disease processes, but essentially this is infection of the cervix, and this is going to present with things like pelvic pain, cervical or vaginal discharge, especially something that's purulent, or in the case of Gardnerella infection, gray and fishy, presenting with our clue cells, which we talked about earlier. And then this is usually going to have an erythematous and friable cervix, which can also happen in cervical cancer, but this is going to be more of acute onset, whereas our cervical cancer is going to be more chronic. And our management here is going to be antimicrobials, depending on what organism is identified and deciding on whether or not empiric treatment is necessary. These are details that will be covered more in our infectious disease unit. So in terms of our high yield review, it's important to know that cervical pathology is happening at our transformation zone, and the big heavy hitter in terms of a risk factor is going to be HPV exposure. We talked about our progression through the transformation zone from CIN1 to invasive disease that penetrates through the basement membrane, and then we talked about our microbiology and our histology findings that are high yield in terms of the types of HPV and the types of pathognomonic cells like coilocytes, and then we talked about how invasive disease is going to present with urinary complaints or urinary aberrations on lab values, and then we wrapped up by talking about cervicitis and how this is going to be an acute cervical problem related to sexual exposure to different microbials. I hope you guys enjoyed this video. I can't wait to see you guys in the next one. Bye! Alright guys, let's get busy talking about ovarian cancer. In this video, we're going to be talking about the overarching themes of ovarian cancer, and then we're going to break down into tables to get the nitty-gritty details that you need to know for test day that correspond to the various types of ovarian cancers. So let's start out by talking about the pathophysiology, which is going to be neoplastic transformation of ovarian tissue. Now we have different types of ovarian tissue which are going to transform, and we'll talk about that a little bit later, but I wanted to start out by talking about some of the etiologies or the risk factors of our ovarian cancers. So it's going to be the most common adnexal mass in our females greater than 55. So this is going to be a diagnosis you're usually expecting in someone who's a postmenopausal female. It's not always going to be that way, but that's what I want you guys to be compartmentalizing ovarian cancer as. Additionally, I want you to look out for some historical risk factors, and these historical risk factors are almost all going to be related to increased estrogen exposure. We know that the ovarian tissues are sensitive to hormones, and estrogen exposure is actually going to lead to an increased risk of cancer. So we know that with increased age, you've just been around on this earth long enough to get more estrogen exposure. So that is going to be a risk factor. In terms of PCOS, we know that there is failure of follicles to rupture, and this leads to increased levels of estrogen in our patients with PCOS. So this is a risk factor for ovarian cancer as well. You can also imagine that you had a lot of cysts in your ovary. This is going to cause a lot of irritation, and we know that irritation can lead to transformation in tissue, so this is another reason why PCOS is a risk factor. In terms of endometriosis, we know that endometriosis is uterine tissue that has migrated out of the endometrium, and it can get stuck on the ovaries, and it can form these things called chocolate cysts. They can be really irritative, and also they're going to be sensitive to changes in hormones as well. So it's kind of getting this double whammy. We're getting estrogen that's going to cause this uterine tissue to grow, and it's going to irritate the ovary more, and it's going to lead to an increased risk of cancer. And then finally, infertility. We know that pregnancy is protective against a lot of our female cancers because it is a period when we are not being exposed to quite as much estrogen, because we know that progesterone is going to dominate the period of pregnancy, and so pregnancy you can think of as a protective factor against ovarian cancer. Now let's move on to some other risk factors. These are going to be more molecular genetics type risk factors. So we have our BRCA1 or 2 mutations. We know that BRCA is a tumor suppressor gene. Specifically, it is a caretaker gene, so it is going to help repair DNA in cells that have undergone DNA damage, and this is going to be protective against ovarian cancer. We have Lynch syndrome, which is going to be a risk factor, and Lynch syndrome is a collective group of cancers that affect people, and Lynch syndrome is going to be inherited. So if you know you have a family history of Lynch syndrome with things like colon cancer and ovarian cancer, that would be something in a vignette that might lead you to an increased risk factor for ovarian cancer. And finally, we have CA125, which stands for cancer antigen 125, and this is a really useful protein marker for sensing how well an ovarian tumor is responding to therapy. So if ovarian tumors are responding well, this level will go down. However, if they are not responding well, this level will go up. So it's useful as a prognostic factor, and it's less useful as a diagnostic factor. That's something they like to ask about on test day. Lastly, let's talk about some protective factors. So these are going to be multiparity, breastfeeding, OCPs, as well as tubal ligation, and you can think of these as all things that are preventing ovulation, right? So if we prevent ovulation, we're not getting those follicles rupturing out of the ovary every month, and those tiny ruptures in the ovary every month are going to lead you to an increase of ovarian cancer. And so if we can reduce those things by making sure that a woman is not ovulating, that is going to help be protective from ovarian cancer. Now let's move on to talk about the different types of ovarian cancer that we're going to cover in more detail in our tables. I just want to give an overview. So starting with epithelial tumors, these are going to be the ovarian surface epithelium that turns into cancer. So specifically, that's going to be this area that I'm highlighting here right along the surface of our ovary, and these are going to be serous or mucinous producing. So I like to think of these as like fluid producing tumors, and they're going to be on that external epithelia. That ovarian coating is what that's going to be, and it's going to usually be benign because these are just going to be surface epithelial tumors, and they tend to be relatively benign. They don't go crazy. They just produce a lot of cystic fluid, a lot of mucinous fluid, as opposed to, let's talk about our germ cell tumors, which are going to be coming from our primordial germ cells. So our primordial germ cells in this diagram, which I'm going to highlight highlight in gray here are these little eggs. And so the little eggs are what are actually going to turn into cancer. And we know that these are really multipotent cells. So they have the ability to transform into a variety of things because they are largely undifferentiated. So we can get things like yolk sac tumors, which are going to be made of extra embryonic tissue, teratomas, which are going to be made of somatic tissues, and then dysgerminomas, which are going to be made of undifferentiated cells. They're completely plastic. They can pretty much turn into anything at this point. And so it's important to know that these types of cells are going to be more likely to be benign or malignant depending on what they turn into. And then finally, we have our sex cord tumors, which are going to be made largely of follicle or stroma. And when I refer to follicle or stroma, I refer to the part that is surrounding the egg. So these would be the granulosa cells that support the developing follicle, and then stroma is going to be the part of the ovary here that is supportive and also making some hormones. So this can be Sertoli or granulosa cells, and the stromal variants, which are going to be the portions here inside the stroma, are going to be composed of fibroblasts or primitive gonadal stroma, whereas the ones that are in the follicle are going to be mainly granulosa cells, Sertoli cells, theca lutein cells, things like that. And then these can be benign or malignant as well. And then I just want to wrap up with the incidence with our endometrial, then ovarian, and then cervical in the order of most common cancers affecting our female patients. So stay tuned for our tables, and we'll get into more detail on each of these cancer types. All right, guys, let's get busy talking about breast cancer. Let's start out by talking about the pathophysiology. It's going to be really similar to our other cancers. It's going to be neoplastic transformation, but this time the tissue in question is going to be our breast tissue. However, we need to know two important types of breast tissue on exam day, and that is going to be our ductal tissue and also our lobular tissue. So let's go ahead and take a closer look at this in our anatomical diagram. We'll start out with our ductal tissue. So our ductal tissue, I'm going to highlight here in blue, and you can see it's out here towards the tip of the nipple, and this is the tissue that is responsible for expressing milk out to the baby. And then behind that we have our lobular tissue, which I'm highlighting here in green, and this is going to be the tissue that is responsible for creating milk. So these are the milk producing lobules, and the ducts are where the milk that has been created goes out towards the baby. So let's talk about some risk factors and background when it comes to breast cancer, because these are things that test writers love to ask on test day. So let's start out by talking about increased incidence with increased age. And this makes sense. This is a general rule that applies to most of our cancers. The longer that you live here on Earth, the more time you have to be exposed to things like radiation or chemical exposures and just cell breakdown and damage. And this can lead to increased risks of cancer, including breast cancer. Additionally, having a family history is going to be an important factor in your risk of developing breast cancer. There are two specific groups that are important on test day, and this is going to be that white patients are more common in getting breast cancer overall, and then our black patients are more common to get something called triple negative breast cancer. And I want you guys to hold on to this idea of a triple negative breast cancer because it's referring to being negative for certain breast cancer receptors. And we're going to talk about this a little later on, so hold on to that in your mind and we'll revisit that. Additionally, let's talk about BRCA1 and 2 mutations. So BRCA is going to be a big hitter on test day, and this is because it is a special tumor suppressor gene. So it's a tumor suppressor gene, and it's also referred to as a caretaker gene. And the reason why it's a caretaker is because it's responsible for DNA repair. However, we can get mutations in BRCA. These are usually autosomal dominant mutations, and this is going to be important on test day. They like to ask about the inheritance pattern. Another risk factor to know on test day is going to be increased estrogen exposure. We know that breast tissue is estrogen sensitive, and therefore increased levels of estrogen are going to lead you to increased levels of cancer. Now, some periods of time in our life where we have increased estrogen exposure are going to be when we are not pregnant. So women who never got pregnant or who never breastfed, during those periods of their lives, they were exposed to more estrogen than women who were pregnant or who were breastfeeding, because during those periods of time, those people tend to have less levels of estrogen because pregnancy, we know, is largely dominated by progesterone, and when we're breastfeeding, our menstrual cycle stops, so we are not producing those big surges in estrogen. So having babies or breastfeeding are protective factors against breast cancer. Additionally, having early periods or late menopause are risk factors, because if you start menstruating early, your estrogen burden goes up much earlier in life, and if you menstruate later on in your life, your estrogen burden is continuing later than other women who may have stopped menstruating earlier. Lastly, let's talk about alcohol use. This is going to be a risk factor for a lot of cancers cancers, and breast cancer here is included. And then we can also have breast cancer in our male patients. And the things that test writers like to ask about is that Klinefelter's puts you at an increased risk, and also BRCA2 mutations. And we talked about how BRCA works, how it codes for a tumor suppressing caretaker protein. And so that's going to be an important thing in terms of our male patients for BRCA2 specifically. Lastly, let's talk about our prognosis, and this is going to be guided by our biopsies. So we're going to get biopsies of our tumor and also biopsies of the lymph nodes surrounding the tumor, and this is where we look for the receptors. So I was talking about triple negative breast cancer earlier, and so we have specific receptors on our breast cancer tissue, and these are going to tell us how receptive breast cancer is to certain treatments or the prognostic values. And this is why triple negative breast cancer in Black patients is usually a really sad diagnosis to hear, because this is an exceptionally aggressive type of cancer. So let's talk a little bit about some of our receptors. So what we have here is overexpression of estrogen and progesterone receptors. Some specific ones that we need to know on test day are going to be CERB2, HER2, and EGF. And it's important to know that triple negative is going to be the most aggressive type of breast cancer. This is going to be more common in our Black patients. Lastly, let's talk a little bit about our presentation. This is going to be a general rule for breast cancers. We're going to go over some tables that have more specifics later on in a bit, but I wanted to give you guys some general rules. So the presentation is going to be variable, but usually we're going to have some type of mass. This is usually characteristic, but it doesn't always have to be there. Additionally, we can see types of nipple discharge. Usually blood-tinged nipple discharge is going to be leading you down the breast cancer route, as opposed to, let's say, milk that's coming out of the nipple. That could be something like a prolactinoma or a drug that is causing galactorrhea. Additionally, breast ulcerations, edema of the arm, or lymphadenopathy, especially in the axilla, this is where the drainage of the breast tissue goes, is going to be characteristic of breast cancer. And then our invasive tumors are going to cause some more significant findings. So our invasive tumors are going to involve the pectoral muscles and Cooper's ligaments. And let's take a look at that anatomy. So if we look at our pectoral muscles here, it's these muscles here that we're viewing in our sagittal plane, and then our Cooper's ligaments are going to be ligaments that support the breast. So you can imagine that if you had a big tumor here, which I'm denoting with this star, it's going to have a real estate effect where it's going to be pushing on these muscles, pulling on ligaments, and this can cause the skin to dimple or the nipple to invert because it's changing the architecture of our breast tissue. And so this is going to be something to be on the lookout on test day. And then finally, I just want to highlight for you guys the skin dimpling and the nipple retraction and inversion. We're going to talk about all the specifics of our specific tumors and how they present in the tables to come, so stay tuned for that. Alright guys, let's get busy talking about our benign breast pathology. Let's start out by talking about fibrocystic changes. And fibrocystic changes are going to be the most common benign breast lesion that we encounter. This is most commonly going to occur in our patients who are ages 20 to 50. So this is going to be our premenopausal population who is still menstruating. And this is going to be the most common benign breast lesion, like I said, and it's going to present as bilateral and multifocal bumps on both sides. So it's going to be plus or minus pain. You're going to have these lumpy, bumpy breasts. And let's take a look at why this happens. So this is largely going to be in the ductal tissues out here in this portion of the breast. And essentially what is happening here is these ductal tissues are getting filled with these cystic-like fluid blobs. And so you're going to have this described as fluid-filled ducts and blue domes. So if you look at this on gross specimen and you're like actually slice a breast in sagittal view and look, these fluid-filled cysts actually turn blue in color. And so they get this blue dome-like description. They like to talk about that on test day, and I want you guys to know that there's a small increased risk of cancer with this condition. And additionally, it's important to know that there are some key types that we need to know about. So there are going to be papillary apocrine changes in general throughout this breast tissue, and there are two types: sclerosing adenosis, which is going to be defined by stromal fibrosis and acini plus or minus calcification, as well as epithelial hyperplasia, which is going to be described as terminal duct cells plus or minus lobular epithelium. Now, largely on test day, it's most likely that you will get histological descriptions of this instead of a picture, but it is possible for you to see a picture. And I want you to appreciate that these ductal tissues here are just full of this white fluid. So if we zoom in here, you can see that what I'm highlighting here is the lining of the duct, and it's going to be filled with fluid. And this fluid just kind of sits around and it makes these big cysts that occur bilaterally. And this is what you're going to expect in this patient population. Now, let's move on to talk about fat necrosis. And if we look at fat necrosis on our model of our breast anatomy, the fat tissue is all this golden tissue on the periphery of the breast here in our model in sagittal view. This is going to present as a painless lump, usually after trauma, but it doesn't have to involve trauma. But we know that fat tissue is really sensitive to physical manipulation. So if you get someone who was hit in the breast, this can cause this fat necrosis. But this lump is going to be painless, even though the trauma could have been painful. This usually presents a few weeks after the trauma itself. On mammography, which is a special type of imaging used to image the breast, we're going to see calcified oil cysts. That is a key buzzword here for our fat necrosis. And on histology, where I think you will be most likely to see something on exam day, you will see necrotic fat and lipid-laden macrophages, which we call foam cells. So let's take a look at these. This is a really easy histology to spot. We have these big globules, these big foam cells, these big macrophages that are laden with fat, and this is something that you would expect to see in a patient with fat necrosis of the breast. Moving on, let's talk about lactational mastitis, and this is going to be occurring in our patients who are actively breastfeeding. And essentially what happens here is we get some milk stasis. So our milk is not flowing out of the nipple as fast as it needs to. This could be because a patient is having trouble breastfeeding her child. Maybe her child is not in a state where it's able to breastfeed, but the body is still producing milk. And so that milk sits around in the duct and there's stasis there. And we know that stasis is a great breeding ground for bacteria. And so bacteria, namely Staph aureus being the most common, are going to get into that static breast milk and they're going to start breeding and multiplying. And then when the baby is breastfeeding, it's going to be chewing and gnawing on the nipple, creating small little lacerations, and those can get infected. So you have this superimposed infection from this infected milk. So let's talk about this a little bit closer. So recent breastfeeding, milk stasis leading to bacterial breeding. Those bacteria are going to infiltrate the cracks in the skin and it's going to lead to a painful red lesion, usually around the nipple, and it's going to be worse with breastfeeding. Now, this is going to be worse with breastfeeding, which is interesting because our management for this is actually to continue breastfeeding, which is kind of funny, but it's important that we avoid that stasis because that was the initial insult. That milk stasis is the reason why all of this occurred. So we need to encourage our patients to continue breastfeeding, and then we're going to give them antibiotics that can cover Staph aureus because that is going to be the most common cause of this. If we look over here, this is a great example. You see this really red inflamed breast tissue, and this is due to the Staph aureus infection from the initial milk stasis. Lastly, let's talk about our gynecomastia, and this is going to be when we have breast tissue development in our male patients. So male patients usually do not have excessive breast tissue. However, in the setting of increased estrogen or decreased testosterone, we can expect to see gynecomastia in our males. So male breast tissue development due to hormonal imbalance, increased estrogen, and decreased testosterone. And so we can talk about a couple of things that can lead to this imbalance. And when it comes to these questions about gynecomastia, it is history, history, history. Knowing the history of the patient is going to lead you to this diagnosis. So usually we're going to see this in the newborn period, during puberty, or in the elderly. And this is because these are periods when we can get hormonal imbalances. Some examples are going to be hypogonadism. When we have hypogonadism, the testes are not going to be producing enough testosterone, and so the imbalance of peripheral estrogen and testosterone made in the gonads is going to be out of balance, and this is going to cause breast development. Additionally, cirrhosis is super interesting because in patients with cirrhosis, they are having difficulty making proteins, and these proteins range from albumin to a number of other synthetic factors like coagulation factors that the liver is responsible for making. The liver also makes something called sex hormone binding globulin, and this is responsible for kind of managing and shuttling our sex hormones like testosterone and estrogen throughout the bloodstream. And when this protein is missing, it is not able to do its balancing act job of making sure that we have an equal balance of estrogen and testosterone. And so these patients with cirrhosis and an absence of enough sex binding globulin protein can actually go on to develop gynecomastia because they have a relative increase in the effects of estrogen. And I think that's some really cool pathophysiology, and it's something that you should be aware of on test day because they love to ask third order questions relating to cirrhotics and having gynecomastia. Lastly, let's talk about some drugs: spironolactone, finasteride, ketoconazole, cimetidine. These are all drugs that can alter the balance of testosterone and estrogen, and so if our male patients are taking these drugs, we can expect them to have a hormonal imbalance, and this can lead to gynecomastia. Lastly, exogenous steroids. This is going to be a huge one on test test day. The history is going to be a patient usually in their 20s or 30s who is presenting to a primary care clinic with acne on their back, gynecomastia, perhaps some shrunken testicles, male pattern hair loss, and this is going to be someone who's like obsessed with going to the gym. They have a big muscle mass. They communicate to you that they love working out, and this is someone who you might suspect exogenous steroid use for the purpose of gaining muscle. And what can happen is when we have exogenous steroids, especially testosterone, this testosterone can be peripherally converted to estrogen, and this estrogen is going to go on to cause gynecomastia. And so you want to be on the lookout for that vignette of the young male obsessed with the gym with acne on the back, large muscle mass, small testes, and gynecomastia. That's going to be pointing you towards exogenous steroid use. Cannot stress how high yield this is on exam day. I hope you guys enjoyed this video on benign breast conditions. We're going to move on now to talk about some of our other conditions of the breast. All right, let's move on to talk about our benign breast tumors. We're going to start out by talking about fibroadenoma, and this is going to be common in our females under 35, and this is actually going to be the most common breast tumor in our patients under 35, and this is really reassuring because this is a tumor that has no increased cancer risk. So if a patient has this, there is no increased rate of cancer. This is going to be completely benign. And importantly, on exam, this is going to be a small, mobile, well-defined mass. And this is a little bit different from our fibrocystic changes, which are a little bit like homogeneous, kind of these fibrous threads or cords that can be present bilaterally, whereas our fibroadenomas are going to be a single discrete mass, and this is going to be composed of fibrous tissues and glands, and these are going to be hormone sensitive. So as during the menstrual cycle, when a patient has increased estrogen, we're going to get increased size and tenderness of this tumor. So a patient during a certain part of their cycle may complain of increased pain or notice that this part of their tumor gets a little bit bigger. And if we look at this on ultrasound, we're going to see here that this is a really discrete, well-defined mass. And I want you guys to take note of the color of this ultrasound. So the tissue here really matches the surrounding tissue because this is kind of a fibrous fatty tissue that matches the surrounding breast tissue. And this is going to be in distinct contrast to our next tumor, which we're going to talk about. So let's move on now to talk about our intraductal papillomas, which I'm going to highlight here in blue. And these are going to have a small increased risk of cancer. And these are going to be located in our ductal tissue. So if we zoom in, our ductal tissue is right here underneath the areola. That's where all the milk that comes from the glandular tissue is going to coalesce. And with these tumors, we're going to see fibroepithelial tissue within our lactiferous ducts. And like I said, this is going to be classically subareolar. And these can have serous or bloody discharge. And this is going to be a key part of history. If you have a patient with some discharge and a lump, this is going to be on your differential. And I want to point you out towards the ultrasound findings here. And notice that this tumor here is going to be composed of fluid. So it's a really fluid-laden tumor, and fluid on ultrasound is going to be much more black than a fibroma. So if you look, the tissue characteristic here is going to be different. This matches surrounding tissue, whereas this is much blacker than the surrounding white tissue here, and that's going to be a key thing to differentiate these two types of tumors. Lastly, let's talk about our phylloides tumors, which are going to be really high yield on the exam because they really stick out, and this is going to be common in our older patients. So this is going to be ages 50 to 60. There's a small portion of these tumors that are going to progress to malignancy, but this is usually a small risk, and these are usually going to be a painless tumor. These are going to present as a large mass, and this is all about histology here. So the mass is made of connective tissue and cysts, and if we're to look at this under our histology, this is going to be described as leaf-like lobulations. This is super high yield. If you look here, these look like leaves. If we were to kind of like outline them, these are like leafy projections. This is a histology picture you guys really want to burn into your memory because it's super high yield. If you see this, this is going to be a phylloides tumor until proven otherwise. If you hear that buzzword leaf-like lobulations, this needs to be on the top of your differential. Let's move on now to talk about our non-invasive breast carcinomas. So these are going to be carcinomas which are not going to be completely benign. However, these are tumors that are non-invasive or not in an invasive stage of their presentation. Let's start by talking about ductal carcinoma in situ. So within the name, this is going to be all about ductal tissue. So we're going to expect it here in the area of the ducts as opposed to the glands. And these are going to be characterized by ductal atypia. So we're going to have a lot of cancerous cells that are going to be filling the ducts of the breast tissue. So our ductal lumens are going to be chock full of tumor cells here, and these are going to be characterized by microcalcifications on mammography. And importantly here, this is an in situ lesion, and in situ means it has not penetrated the basement membrane. So there's going to be no basement membrane penetration here, and there's actually going to be a special subtype that might come up on test day called cometocarcinoma, and this is going to be characterized by high-grade nuclei with central necrosis as well as dystrophic calcification. That dystrophic calcification might be something that could be picked up on mammography. And let's take a look at this histology here. If we zoom in, we're going to see that this is all cancerous material filling the duct lumen. So the duct lumen I have kind of outlined, and all this cancerous material is in here. We're going to see there's like a lot of nucleic activity, right? There's a lot of nuclei in here, and these are all cancer cells, but this has not yet penetrated the basement membrane, so this is still considered an in situ lesion. And so this is going to be ductal carcinoma in situ, has not pierced through the basement membrane. Let's move on now to talk about Paget's disease, which is going to be another form of ductal carcinoma. However, this has like spread to the epidermis. So remember previously how I was talking about how ductal carcinoma happens right here at the duct. Our Paget's disease of the breast is actually going to occur out here on the skin. And so this is going to be an important differentiation. It's the same pathology happening here, but it's going to be a different location. So we're going to have eczematous patches on the nipple and areola. And an important thing on your differential here is going to be eczema, because these lesions look just like eczema. And so like I said before, this is going to be a DCIS extension to the skin of the nipple, and it's going to be characterized by Paget cells. And Paget cells are going to be intraepithelial adenocarcinoma cells. A great example of it is the histology that I have here. So if we zoom in and take a look, this is beautiful, beautiful histology. We also have Paget's disease in other parts of the body, and it always looks like this. So we have this really beautiful hyperkeratotic lesion here at the top, and then we have like these vacuated cells which are characterized as Paget cells, and you can see they're all throughout here in the epidermis, and then we have our underlying dermis below, and it makes these beautiful layering effect. And this is going to be characteristic of all Paget's disease across the body when it comes to skin. And if we were to look at this on physical exam, it would look like this. It's like this really eczematous area around the nipple, and this is going to be classic for Paget's disease of the breast. Let's wrap up by talking about our lobular carcinoma in situ. So this is going to be disease process of the lobules of our breast. So previously we were talking about nipple and ductal, but now we're talking about our lobule area, which is going to be all back here. This is going to be our milk producing tissue, and this is going to be something that's found incidentally on biopsy. And so when we find it incidentally on biopsy, then it's going to alert us that this patient needs to be monitored. Although this is an in situ lesion, it has the potential to progress to not be an in situ lesion anymore, aka to pierce through the basement membrane. This is going to be an increased risk of cancer in either breast. I want to zoom in here and talk a little bit more about the molecular biology of our lobular carcinoma in situ. So I'm going to draw two layers of connective tissue for us here, and then I'm going to insert these molecules called cadherins, and I'm going to designate them as these little boxes here. And cadherins, if you remember from the molecular biology importance on step 1, are going to be connective molecules, and they're going to be calcium mediated. So I'm going to draw in these little calcium blue dots. I'm going to label them here Ca2+, because that is how we denote calcium in our step 1 exam. And then there's one more player here, and that's going to be catenins. And catenins are going to help with the function of cadherins. So I'm going to draw these green dots kind of lacing through this matrix here, and these are going to represent our catenins. And these are all responsible for connective tissue function. And so if you have a lobular carcinoma in situ, we expect them to have decreased cadherin expression and to be P120 catenin positive. And this is essentially like the initial brewing factor of this type of cancer. And this type of cancer can progress to not being in situ anymore. And when this happens, we're going to get some changes that I want you guys to hang on to, because we're going to talk about the non-in situ version of this cancer. But I want you guys to note the important molecular players when talking about this type of cancer. And so if we look here, our lobular carcinoma in situ is going to be here, and this is because this is all confined within the basement membrane. And this is as opposed to our invasive lobular carcinoma, which I'm going to highlight in red here, which has kind of escaped the confines of the basement membrane. And we're going to talk about this a little bit more in the next slide, but I wanted to kind of prime you guys for that. So remember, these are all going to be non-invasive carcinomas on this slide. They have not broken through the basement membrane. And we're going to move on now to our invasive carcinomas in the next slide. All right, let's wrap up by talking about our invasive carcinomas of the breast. Remember, these are going to be cancers that break through the basement membrane and are really aggressive and malignant. So these are the ones that we really do not want to diagnose our patients with. Let's start by talking about invasive ductal carcinoma. This is going to be in the ductal region. And so this is going to be the progression of our ductal carcinoma in situ. This is going to be the most common type of invasive breast cancer. And this is often going to be bilateral and multifocal. So this is really nasty disease process. It's going to present as a hard mass with well-defined margins. This is going to be firm and fibrous tissue, and it's going to have desmoplastic stroma. Desmoplastic stroma is referring to the fact that fibrous tissue is trying to grow around this cancer and contain it, and so that is the response of the body to this really invasive cancer. And then these cancer cells are going to be described as small, glandular, and duct-like cells because this is going to be a cancer that is arising from the ductal tissue. Let's move on now to talk about our invasive lobular carcinoma. This is also going to be frequently bilateral, so this is going to be nasty disease as well. And like we talked about with our lobular carcinoma in situ, this is going to be all about cadherin expression. So here we have decreased E-cadherin expression, and this is going to lead to tissues that do not stick together well. So this is going to present itself as metastatic disease that is spreading away from its original location. And important here is going to be single file cells, which we are going to zoom in and look at here. And essentially these cells are going to line up in single file because they are now migrating. They have lost their cadherin expression. They are no longer sticking together. And so they're kind of marching out of their original location past the basement membrane and going on to metastasize. This is going to have a lack of duct formation because the ducts are essentially getting so deranged that these cells are spreading everywhere. And this is frequently without desmoplastic response. And remember, desmoplastic response is the body trying to create fibrous tissue to contain this cancer. And this is not happening because this is a really aggressive malignant disease process. So if we look here, let's do some compare and contrast. Our lobular carcinoma in situ is all contained nicely here within the basement membrane. However, with our invasive lobular carcinoma, we're going to start to get single file cells like these here, some more single file cells here. So these have lost their cadherin expression and they are just going on a march. They are marching to malignancy. That's how I like to remember this. And this is going to be a really, really poor prognostic sign. And this is the characteristic lack of desmoplastic response in this invasive disease process. Let's move on now to talking about medullary carcinoma. And this is going to be characterized by specific molecular things that you have to know with regard to this cancer. It's unlikely that you're going to get histological images, but you're going to have to know that these are large anaplastic cells in sheets and that they're going to be lymphocytes and plasma cells. So I want to highlight this in purple because I think of lymphocytes and plasma cells as really purple cells with like big nuclei. And so that's a way to really recognize this on test day. And it's going to be a well circumscribed lesion and it's going to be a mimic of fibroadenoma. However, the fact that this has the lymphocytes and the plasma cells is going to clue you into the fact that this is an aggressive disease type. Lastly, let's talk about our inflammatory carcinoma, which I'm going to highlight in orange, and you guys will see why in a second. This is a really, really terrible disease with a poor prognosis. Only 50% of patients survive past 5 years, and this is going to be a mimic of eczema and Paget's disease, so it's important to rule this out when you're working up patients. It's going to present as a painful, warm, swollen erythematous lesion or breast, and there's often no palpable mass here. So how are you going to recognize this? And the key physical exam finding is something called peau d'orange, and peau d'orange roughly translates to orange skin, and this is caused from hair follicles that are undergoing changes because of this cancer. And so this peau d'orange finding is what you see in the picture here in the chart, and it looks like the skin of an orange. And so if you were to see a picture of this on exam day, this is a big high yield red flag for our inflammatory carcinoma, and this is caused by invasion of dermal lymphatics. So we know that our dermis is going to be drained by lymphatics here, and so when those lymphatics are invaded by this cancer, it's causing like this little orange dimpling effect at the surface of the skin, and this is how you're going to nail this one on test day. So remember guys, everything on this slide is going to be invasive malignant disease, and this is important to separate from our previous slides, which were non-invasive carcinomas or benign lesions altogether. I hope you guys enjoyed this video on breast cancer. Can't wait to see you guys in the next one. Bye!